Okay, let's begin. A warm welcome and a good afternoon to everyone who is here, or morning or evening, depending where you're watching this live web meeting today. My name is Dr. Fahim Shakur. I'm a general practitioner in the northwest of England. Really pleased to also introduce Dr. Mehran Javed, my co-host today from MEDtalkx, who's a consultant psychiatrist. And between us, we hope to carry you through a couple of hours of very informative education and perhaps even a bit of entertainment as well in terms of actual content to do with COVID-19 and the problems to do with that, along with major public health issues that are going on. If at any stage you have any questions, please do ask us on the chat function. We have the normal system for Zoom here. If you look at the bottom of your screen, for those of you unfamiliar with Zoom, please familiarize yourself with the control settings there, and we will try and get through questions. The format today is quite a simple one. We hope to have 10-minute presentations from our speakers. Please forgive us, two of our speakers, due to unavoidable circumstances, are unable to join us today. So there will be 8 speakers giving approximately 80 minutes and also a minute or two of questions after each speaker in case they're unable to join us for the Q&A session towards the end of the afternoon. We have, if you can see in the chat function in the actual box, there's the feedback form. Feedback is a gift, and this is the only thing we do ask. If any of the attendees today could please just take 60 to 90 seconds to fill that in. I've tried it myself. It doesn't take long to fill out, and it gives us good information on each speaker and what we can do better for future programs. For those of you who are coming on now, please, can I just remind if you can switch off your audio, and if you do have a lot of background noise, I appreciate it's a Sunday, then please watch this on our YouTube channel. The link is there and you can completely just watch it there. It just means you won't be able to ask any questions as well. Just a final request for those of you who are making questions or the presenters, please do not put any patient identifiable information in any of your presentation or during any of the discourse or discussion, as although there are many healthcare professionals today, as I said before, it is going out live onto YouTube, so be mindful that members of the public can watch today's presentation. I thank you for your attention. I'm sure we'll be talking during the course of the afternoon, and let me please hand over to my co-host, Dr. Mehran Javed.
Thank you, Fahim. And yes, my name is Mehran Javed. I'm an old age psychiatrist in the northwest of England. It's fantastic to see lots of familiar faces, but a great opportunity to also form new educational and professional relationships. So without further ado, let's start with our first presentation. It's with Dr. Ira Leroy, who I do know well as a trainee. She has guided me through my specialist training, but she is an associate professor in geriatric psychiatry at Trinity College Dublin, consultant psychiatrist at St James's Hospital, as well as honorary professor of psychiatry at the University of Manchester. She has a special interest in neuropsychiatry of neurodegenerative movement disorders such as Parkinson's. She's also the chief investigator for the EU-funded SENS-COG study, which is a 5-year comprehensive research program involving 7 countries and 27 investigators. And in addition to that, she has over 120 peer-reviewed publications. So clearly someone with expertise, and I will hand the mic to Dr. Leroy.
Thank you very much, Mehran. It's wonderful to be here. I'm just checking, can everybody hear me all right?
Absolutely fine, Dr. Leroy.
And you can see my screen?
Absolutely fine.
Perfect. Okay, thanks so much. It's wonderful to be here, and thank you everyone for giving up your Sunday evenings to share some time with us. So I'm going to be talking about brain health. So I'm going to start immediately. Now, since brain health may not necessarily be a term that everybody is familiar with or may be using in their clinical practices, I'm just going to step back a little bit historically and instead talk about dementia. Now, a few years ago, dementia wasn't necessarily a term everybody was very familiar with, but now, of course, it is. And so historically, probably only even 10 years ago, D was, or the unmentionable D word, dementia, was something we didn't talk about. We talked about euphemisms, memory loss, memory getting worse with aging, and so on. But I think we're beyond that now. And certainly in the UK, we've moved into the dementia-friendly society. And I think in many areas we're succeeding fairly well. People are not afraid to say that they've got dementia or that somebody, their loved one has dementia or is living with dementia. They're facing the challenges. We see dementia in the newspapers most days. We have singing for dementia, arts for dementia, swimming for dementia. So they're starting to move towards this aspiration of a dementia-friendly society. So I think we're ready now to start thinking one step further about the Healthy Brain Society In other words, that we have an aspiration that one day we move to the point at which fewer people live with dementia because we're living with healthier brains. In other words, that we have a dementia-free society. Now, that's a very strong aspiration, and there'll always be a proportion of people who, unfortunately, because of a number of reasons, particularly genetics, will develop dementia. However, as I will demonstrate in my talk today, you will see that a significant proportion of people do not need to live with dementia if we adopt this idea of a healthy brain society. So let me talk about that for a few minutes. I'll just remind you of the Global Action Plan on the Public Health Response to Dementia, which is between 2017 and 2025. Now, you probably can't read this too well, but as you can see here, the first priority is about dementia as a public health priority. The second one is raising awareness of dementia and developing dementia-friendly societies. But the third one here is actually about dementia risk reduction. So this really speaks to the heart of this idea of a healthy brain society. So what is brain health? Now that's a tricky one because we never really use the term very much. As you can see here, this is from PubMed, and it was really only in about 2011 when that term really started to take off, and it's increased exponentially. So you think we'd kind of understand what it is, but actually nobody really has a very good definition. So this is the results of a survey that I undertook with colleagues of mine around the world. It's about 74 different responses, and you can see a huge range of definitions. It's a broad concept. It can involve well-being of the brain, prevention, the absence of brain disease, health in general, optimal function, ability to keep your mind healthy. So in other words, a whole hodgepodge of different definitions. What does the literature say? Well, the literature is equally as complex and says very different things. So for example, you might have here, Beard and colleagues in 2009 talked about how to stay sharp. That was brain health. On the other hand, you've got Hendry et al. Here from 2006 offering a much more comprehensive definition based on, I'll just read a few words, multifaceted cognitive ability that allows individuals to function independently with a sense of purpose, to make their own decisions, to maintain social connectedness, to prevent, etc., etc. So a long, complex definition that touches on multiple dimensions and also firmly sets brain health within the context of a person's social and cultural context. So that's very different from simply the absence of disease. So what we did recently was we undertook a concept analysis of this idea of brain health to try to really pin down what it is. Now, when you do a concept analysis, some of you may not be familiar with this particular methodology, you try to dissect the concept into its different component parts, of which there are three big bits. One is the attributes of brain health or the characteristics. You try to define those. Then you look at the antecedents of brain health, in other words, the things that lead to the concept occurring. And the third thing is about the consequences. In other words, if you have brain health, what does that mean for your life? So I'm going to touch on these for a minute now. First of all, the attributes. What do the attributes mean? Well, in looking at the literature, as well as pulling in the data from our survey, we can say that the characteristics of brain health include the concept that brain health occurs over a lifespan. It isn't something that appears or doesn't appear. And this also speaks to this idea of the continuum. You don't have good brain health or bad brain health. You have a continuum. You can have optimal brain health or suboptimal brain health, and you can move along that spectrum depending on a number of different factors. Brain health can be subjectively experienced. In other words, I feel that my brain health is optimal or not, and it can also be objectively measured in a number of ways. And finally, it's multidimensional. In other words, it can refer to physiological underpinnings, the cells, the molecules, the connections, the synapses, but it can also refer to how we interact and what our social connections are and the meaningfulness we get out of life. So it's multidimensional and touches on a range of different domains. So using that idea as the attributes, we can say that a proposed definition is this, that brain health is a multidimensional, dynamic state occurring along the life course and incorporating cognitive, emotional, and motor domains underpinned by physiological processes. And it can be objectively measured and subjectively experienced. So, what are the consequences? If you have brain health, what does that mean for your life? Well, it means that potentially you are much more adaptable in terms of adapting to various life circumstances, aging, disease, degeneration. You're also more resilient. You can bounce back from various traumas, insults, or changes in your life or your health. You have a modicum of social connectedness, because ultimately social connectedness is what gives us meaning in life. And also you have independence. You're able to live your life to a certain extent, or to the greatest extent possible within your own limitations, in the way that you want. So this is what we would strive for in achieving brain health. So you can see in remaining dementia-free, or even living with dementia, you would still strive to have these aspects. And that would be on a continuum of optimal to suboptimal. Now, what about the antecedents? What are the conditions that you need to put optimal or suboptimal brain health in the picture? And we can look at these in a couple of different ways. We can look at the risks and the protective factors. So this brings me to the next bit of the definition, namely that brain health is influenced by biopsychosocial determinants, resulting in this continuum of outcomes. So these here are the antecedents. So let me touch on those. I'll start with the risks. What are the risks to brain health? Well, I've taken this picture from my travels around the world, and you can see here that in certain lower middle income countries, in this case, all these are from South Asian countries, there are significant risks to brain health. So for example, living in conditions that might have high security risks, that in other words, create a societal risk. You can say that the COVID pandemic now is one of these situations in which at a societal level, we live in high pressure and high levels of psychological tension. Air quality, diabetes and cardiovascular risk because of people's diets and sedentary behavior. The risk of head injury, you can see here, nobody wearing a helmet. All the beautiful faces, none of them with a helmet. So those are examples of brain health challenges. So let's bring those together, and I'll draw your attention to this very important landmark study, which actually was initially published in 2017, led by Jill Livingston's group out of University College London, looking at dementia prevention, intervention, and care. And it was based on a Lancet Commission report. And what they did both in 2017 and now updated in 2020 is that they looked at the range of these types of risk factors and the implications that they would have for preventing dementia across the life course. And what did they find? Well, they found, importantly, that if you address these risk factors, you theoretically, because this is a model, can prevent up to 40% of dementias. Now, if you extrapolate that to the context of lower and middle income countries, like the example I just showed you, that proportion can potentially go up to 56%. So what are these risk factors? There are now 12. The initial report had 9. And this is based on the current availability of evidence. The first risk factor is about education level, that education less than 12 years, in other words, of the age of 12 years, is a significant risk factor. So is midlife hypertension, obesity, and diabetes. Increased alcohol intake, traumatic brain injury, late life depression, physical inactivity, smoking, air quality, so I gave the example there, social isolation, now we're thinking about COVID, and importantly, hearing loss. Midlife hearing loss accounts for the biggest proportion of the model at 8%, potentially a reversible factor. So this has been a very, very important paper that has now started to influence the way we conceptualize dementia prevention and brain health. So I'm going to focus on hearing impairment because this is one of the things that we've looked at in our SenseCog program. And so this is my colleague Azmi Maharani, and one of her studies, of which she did a number, she showed the difference between the trajectory of cognitive decline, which is this black line, with aging, the normal decline you'd expect, using a number of different large databases, and how that trajectory can be pushed down and exaggerated by having poor hearing. In other words, this is your normal age-related cognitive decline. Add into that hearing impairment, and you can see a more rapid decline. So very important finding, again, suggesting that this idea that potentially, if we were to address this risk factor, our age-related cognitive decline and potentially dementia risk may be lowered. What if you have more than one sensory impairment? What if you have vision impairment and hearing impairment? And so this is where you look at the red line. So the blue line is having a single sensory impairment, but double it up and you've got this additive effect. So having dual sensory impairment makes your cognitive decline trajectory even steeper. So let's move away from risks. What about the protective factors? Now, in other words, can we modify these risks to prevent dementia? That's where things get a little bit tricky because we're still waiting for evidence. This is where you really need very large longitudinal trials comparing people who have the risks and those who don't. And that can be complex. But we can look at epidemiology and get some ideas. So, for example, here's another study by my colleague Azmi Maharani from the SenseCog program. She looked at hearing aid use and tried to see whether using a hearing aid, in other words, modifying your hearing impairment, would alter the rate of cognitive decline. And she used American data for this. So, what she did is she looked at predicted values of episodic memory before and after using a hearing aid. So here's where all the participants received a hearing aid at different times, but they were all standardized in this model here. And what you can see is that the trajectory of decline improves. It becomes less steep after you have received a hearing aid, providing very interesting evidence that, in fact, hearing may be one of these modifiable risk factors. So we can intervene and make a difference. What about clinical trials? There's a number of large-scale clinical trials currently ongoing around the world. Probably the most famous, and the one I'll draw your attention to, is the FINGER study, which comes from Finland. And in this study, a multi-domain intervention looking at nutritional guidance, exercise, cognitive and social activity directed at people at risk of dementia was undertaken and seemed to be quite positive. So this is really driving this idea of brain health clinics and brain health interventions to slow the progression of mild cognitive impairment into dementia. And finally, the evidence synthesis. I'll draw your attention here to this particular set of guidelines. Now, sorry, it's a little bit blurry, but a very nice set of guidelines about risk reduction of cognitive decline and dementia. Now, I won't be able to go through them all, but it's a state of the art as to where we're at in terms of these potential modifiable risk factors, like smoking, nutrition, alcohol, hypertension, diabetes, and so on. And you can see hearing loss at the bottom here. So I will leave you with that, and I will finish my talk. And I think I'm going to hand over to Mehran now, and I'll stop sharing. There we go.
Thank you, Dr. Leroy. That was a very informative talk, which is why I didn't want to interrupt any of it. In terms of questions, obviously you went through many different things. What about memory clinics in the future? What could we do that's not happening now? And what do you anticipate?
I think that's an extremely important question. Memory clinics now in the UK are really based or catered for making a diagnosis of dementia, the clinical syndrome of dementia, and understanding what the underlying disease that results in that dementia is, and then treating people appropriately. The big piece that's missing, now it started in some places in the country, we're seeing this changing, but generally speaking, the big piece that's missing is some kind of support for people who don't quite have dementia, but they have clinically significant cognitive impairment. In other words, people with mild cognitive impairment. So clearly they've got a problem. However, they're not at the stage whereby the system and the services start interacting with them and giving them support. So they fall between the cracks. And this is where potentially brain health clinics can come in. Again, in Scotland, this model has already started. Now, what do I mean by brain health clinic? It essentially means supporting this group of people to try to understand, number one, will they go on to develop dementia? Or is this a non-progressive mild cognitive impairment? Or is it something that'll get better in a year? Of those, all of those, we need to figure out who's the high risk group of the people who go to dementia, and we need to intervene fairly aggressively by addressing all of these risk factors and giving people the information they need so that they can optimize their brain health and potentially slow down the point at which they transfer into or convert into the dementia syndrome. So that really, I think, is the goal. Now, where will that happen? Probably not in secondary care where dementia services currently sit. They should occur in primary care. And that's a big challenge because, as everybody knows, primary care services are really quite overburdened. And to take on this program of work will be quite difficult. So there's just something to keep in mind.
Excellent. We had a couple of questions which are similar, so I'll amalgamate them into one. And they're asking about the hearing loss and dementia issue. So in your presentation, you mentioned about middle-age hearing loss, but is it childhood hearing loss a factor as well? And really, another person's asking how long the hearing loss or visual impairment's been present. You know, is it congenital or not? Can you tell us a little bit about that?
I think that's a very important point because along with dementia, in other words, congenital hearing or vision loss is not associated with an increased risk of dementia. This is middle-age hearing loss, and the vision impairments data are supported but not strong enough to be fitting into the model of, for example, the dementia prevention model that Jill Livingston has put forward. But those data are starting to appear. So this is acquired hearing and vision loss. And This is why it's an important aspect in terms of potentially preventing that conversion in the future to dementia, or at least one aspect of it, because it is only one factor in this rather complex model. Now, why is it the case? Does the hearing loss cause dementia? Probably not. Does cognitive impairment cause the hearing impairment? Probably not. It's likely that there's some kind of common factor, a common gremlin that is involved with degeneration that is affecting vision, hearing, and cognitive pathways. But again, that's a simplistic model. It's likely multifactorial and multiple different pathways that are coming at play, and all of these in parallel degenerating with time.
Excellent. Slightly different tack. What is the role of metformin in slowing down the process of dementia, Dr. Leroy?
Metformin, well, there are no large-scale trials of metformin in slowing that down, or rather, I should say, Cochrane reviews have not suggested that this is the case. There are still ongoing studies of a number of different agents looking at prevention, and I think we're going to see a lot more of those in the future. So I think we'll just have a rain check on that for now. But ultimately, if you are managing your overall risk factors, that in itself will be important in terms of brain health overall and decreasing your risk.
Excellent. And just the last question, I know you have to leave after this, Dr. Leroy. Would you advocate screening of the general population for visual and hearing loss?
Oh, that's a very interesting question. I'll leave that to the optometry, the Royal College of Optometrists and also the audiologists. I think that's probably not feasible. However, I certainly think that people in at-risk groups should have much greater attention paid to the hearing and vision impairment, particularly as people get older and move into dementia. We have very good data suggesting that people in those risk categories have significantly under-detected and under-corrected hearing and vision impairment. Now, once people develop dementia, that's not about prevention, that's about living optimally with dementia as your diagnosis. But it's very important to consider those factors. And I think anyone who works in a memory clinic will know that probably 80% of people coming in the door have hearing impairment, but will not have their hearing either assessed or corrected adequately. So this is a very important public health move that we need to think about in the near future, or now.
Okay. I did say last, but there's just been one last question that squeezed in, Dr. Leroy, if you can please entertain us. 60 to 80%, the reason of dementia is Alzheimer's. Then why there is no drug for Alzheimer's?
What's the question?
The question was 60 to 80% of the reason for dementia is caused by Alzheimer's. So why is there still no drug for Alzheimer's?
Oh, why is there no drug for no drug for Alzheimer's? Well, I don't know it's necessarily related to the fact that it's common, because Alzheimer's is a very complex condition, and I don't think we necessarily understand it very well. We are on the cusp of getting licensed for a particular disease-modifying therapy for Alzheimer's disease. Whether it will address the entire problem, I suspect not, because, again, many people we see with Alzheimer's disease have multifactorial problems, including cerebrovascular disease. And I think there's also discussion about whether we're hitting the right target. In other words, most of the clinical trials to date have targeted amyloid. Now, is amyloid a causative factor, or is it just a byproduct of that pathological process? And in other words, are we targeting the wrong thing? So we've some ways to go, but we're certainly much closer than we were even 5 years ago. And probably within the next number of years, we will have a disease-modifying therapy. However, it will be for a certain proportion of people. And the people who it will be for will be those who have demonstrated amyloid positivity in the case of the drug that's about to be licensed, number one, which doesn't apply to everybody who looks like Alzheimer's. And number two, it'll have to be for people in the very earliest stages of the disease. In other words, in the pre-dementia stage. So then the onus is on us to be able to detect people with Alzheimer's disease in their brains before they have dementia, because otherwise it'll be too late to be using these kinds of therapies.
Thank you, Dr. Leroy, and thank you for your participation on today's web meeting. I'll hand over to Mehran to introduce our next presenter.
Thank you again, Dr. Leroy, and yes, thank you for him. So our next guest is Dr. Shazli Azmi, and she's a consultant in diabetes and endocrinology in the northwest of England. She graduated from the University of Manchester and also obtained a PhD from Manchester University with a thesis focusing on longitudinal studies in metabolic neuropathies. She has numerous publications and authored textbook chapters, as well as presented both regionally and internationally, demonstrating an expertise in her field. So over to you, Dr. Azmi.
Thank you very much for that kind introduction, and thank you for inviting me to speak today. That was a fantastic presentation by Dr. Leroy, thank you. So I'm going to talk today about the significance of diabesity. So diabetes and obesity are two massive topics, and it's very difficult to condense it down to 10 minutes. So I've just chosen a few things which I'm going to highlight today. So my aims are going to be to discuss diabetes and obesity, prevalence, relationship, and impact, and also touch on the benefits of weight loss. You see here, this is a map of the world. 463 million people worldwide have diabetes. So we're certainly in the midst of a pandemic. If we focus on certain countries that have got more than 20 million people with diabetes, so we've got America, China, India, where the actual population is really significant as to how many people actually have diabetes, which is closely followed by the rest of the world. The countries in pink here have 1 to 10 million people. And similarly, looking at the UK, we've got up to about 1 million people. Coming up to the UK and in Europe, there's a significant number of people that have it as well. And the worrying thing is that this number is continuing to increase. It's already been increasing and it's due to increase exponentially. So if we look in 2045, this number is actually going to double. So it's already placing a huge burden on our healthcare as it is, as well as obviously causing a lot of comorbidities and premature cardiovascular death for patients. And if we continues to increase, this is going to be one of the major pandemics of all time. Following this trajectory is also impaired glucose tolerance or prediabetes. So this is the number of people that we know that are diagnosed. However, diabetes being a spectrum, people with prediabetes also have metabolic risk factors such as hypertension, hyperlipidemia, as well as also having mild hypoglycemia, such that they are also exposed to the effects that will ensue once someone develops diabetes. There's also those that are undiagnosed, and there's a big push at the moment to identify these people. And it's actually phenomenal how many people actually are not diagnosed. So if we look in the countries that have a really high population, so looking at America and China and India, again, there's more than 10 million people in these countries who have undiagnosed type 2 diabetes. And this again is closely followed by the other countries in pale pink with this 5 to 10 million. And these people are actually worried because they're walking around in this high metabolic state. They're probably asymptomatic, so there's been no reason for them to actually consult anyone or have any investigations done. They'll be on no treatment for any of their risk factors. And as we've just heard about brain health, this is also contributing to not just your cardiovascular disease and things we know as, there's actually other longer term benefits as well, longer term disadvantages as well. So it's really important that we try and identify these people and get them on the correct treatment, and also offer health and diet and lifestyle advice to them. So what is the impact of diabetes on the population? And I found this quite interesting actually. So this basically shows the percentage of people that will die from diabetes before the age of 60. So when we think about the age of 60, most people would be sort of in the peak of their career, looking forward to retirement, haven't retired yet, and by certain means, it's much lower, the 60s, well before the age of life expectancy in the majority of countries. And if you look at a certain country, there are more than 80% of people with type 2 diabetes who will die before the age of 8. In Africa, for example, 60 to 80% of people will die before the age of 60 with type 2 diabetes. And the Western world sort of closely is following behind. So the countries in dark blue, 40 to 60% of people, so more than half the people with type 2 diabetes will die before the age of 60. And I suppose that's simply just not good enough, because at the end of the day, like I said, at the age of 60, people are at sort of, that's not the age that we expect people to be sort of having premature cardiovascular disease and dying on. So that leads us to believe that our treatment at the moment, our management, is just not up to scratch. We need to do more. We need to be treating the metabolic risk factors a lot more hard. We need to be focusing on it, especially cardiovascular disease, as well as trying to manage the long-term complications, and also getting the people that weren't diagnosed to have adequate treatment. This shows the health-related expenditure in US dollars. So this is basically shows that there's a huge part of the world, pretty much all of North America, big parts of Europe and Asia, that are spending more than $10 billion per year on the management of type 2 diabetes. And then just below that, 200 million to a billion, there's a lot of countries that are spending that much. Certainly in Europe and the UK, 1 to 10 billion. This is a phenomenal amount of money that we're spending on diabetes-related healthcare, and a very small proportion of this is actually the medication. The majority of this cost will be excess inpatient stays, because anyone with diabetes that goes in for pretty much any hospital visit, whether it being sort of planned surgery or in sort of acute infections, there's always excess hospital stay with patients with diabetes. So this is a cost. Dialysis, amputations, surgery related to surgery related to foot disease. All of this leads to a massive expenditure for type 2 diabetes. Moving over to obesity and overweight. So the World Health Organization defines overweight as a BMI above 25 and obese is a BMI above 30. So basically you want to aim for a BMI less than 25. And this is where we need to be aiming to advise patients. However, if you're Asian or about at-risk minority, then your actual BMI needs to be more towards 23, because the risks that they will perceive will actually go up at 23. So it's important that when we advise patients, we advise them correctly, so that any sort of at-risk people are sort of controlling their BMI and waist circumference much better. Obesity has more than doubled since 1980. So again, part of the diabesity pandemic that's ongoing. In 2014, more than 1.9 billion adults were overweight and more than 600 million were obese. And sort of more interestingly, in 2013, 42 million children under the age of 5 were overweight or obese. And this is really worrying, because this is what is adding to the growing population of people who have type 2 diabetes. And in fact, it's being diagnosed earlier and earlier. And when these young children come through, who knows what age they may be diagnosed at. So it's really important that education is provided even younger nowadays. And it's a bit worrying again, because this is in this younger age group, this is an inbuilt kind of lifestyle and diet. This is how they've been perceived. So to change habits is very important. So a lot of work needs to be done to try and make sure that this number is reversed, and these children don't go on to continue being at metabolic risk throughout the majority of their lives. So we know that obesity is associated with increased cardiovascular disease. So basically what this shows is that you've got your group, this is the group here with who are not overweight and have a normal waist-hip ratio. And so this is vascular disease, ischemic heart disease, and hypertension. And basically, as soon as your waist-to-hip ratio goes up, your risk of developing these conditions goes up significantly, as well as if you're obese with a raised waist-to-hip ratio. So this raises the importance of having sort of central obesity, importance of trying to look at central obesity and trying to get people to sort of reverse it with regards to waist circumference as a modifiable risk factor. Just simply by your waist circumference going up and you having abdominal obesity, it puts you at risk. Whether you're obese or not, it puts you at a much higher risk of vascular disease, ischemic heart disease, and hypertension. As I mentioned earlier, diabetes and obesity are very closely interlinked. Obesity is the single most important predictor of type 2 diabetes. So this basically shows as your BMI increases, that your risk of developing diabetes. So as soon as you get to a BMI about 24, the rate starts to increase of diabetes. Once you get to 30, you can see that that tangent is going up even more sort of exponentially. So the higher your BMI, the more likely you are to have type 2 diabetes. It's not to say that everybody with type 2 diabetes is overweight. There is a small proportion who have a normal weight. Similarly, everybody who's got obesity won't have type 2 diabetes. However, if we think of it as a Venn diagram, where you've got diabetes on one side and obesity on the other, you can have a massive proportion in the middle that overlap. And this is the diabesity cohort. This is your people with type 2 diabetes and obesity, and this forms up the majority of the population. And you will have the other two without the other concurrent disease on either side. So I'm going to focus on a few studies and the benefits of weight loss now. So the Look Ahead study looked at the basically what this study showed was that 5 to 10% weight loss, a weight reduction, was associated with a significantly improved cardiovascular risk factors at 1 year. So this was an improvement in HbA1c, blood pressure, and HDL cholesterol and triglycerides, lipid profile. So basically all these things improved with a modest 5 to 10% decrease in weight. Now, obviously it's easy to say it's a modest 5 to 10% decrease in weight, but as you know, anybody who's trying to lose weight, even 5 to 10% can be a struggle. So any weight loss that somebody has is, no matter how small, it will be meaningful. And as this shows, even sort of 5% will have fantastic, phenomenal benefits on somebody's sort of longer term cardiovascular outcomes. The Direct study, so this has gained quite a lot of interest recently and has been sort of quite topical. So this is basically looking at low calorie diets for remission of diabetes. So in this study, they had people with type 2 diabetes for less than 6 years duration who were not on insulin with a variety of BMIs from overweight to obese. They looked at intense treatment, which is the low calorie diet of 800 calories along with weight management intervention as well versus standard care. So this is just standard weight management services. And what do the results show? They're actually quite phenomenal. Almost half the patient participants in the treatment group achieved remission after 1 year. A quarter of participants achieved a 15 kilogram weight loss or more. This highlights a few tables from, a few graphs from this. So if we see here, year 1 and year 2 in the purple is the control group, and the pinky colors are the intervention group. So this shows the percentage achieving remission. In year 1, 45%. In year 2, still more than a third, 35%. And the majority of people who achieved remission were those who had lost more weight. So the more than 15 kilograms, you were in the first year, you were 86% of people achieved remission and 70% at year 2. So the more weight you lost, the more likely you were to achieve remission. And this is very interesting data. The fact that we actually sort of general culture was that diabetes is more of a progressive condition, and there's always this fear of somebody being diagnosed with type 2 diabetes because once they got it and they're on medication, they think that's it. They're just going to progress and progress and progress and eventually go on to insulin. However, recently, our whole paradigm of management of diabetes has changed. There's so many more different medications and new data on cardiovascular disease and renal outcomes, and a lot more options that we have. And in fact, it's shown that perhaps, and coupled with this data, that things can be reversed and we can sort of undo the metabolic effects that are ongoing and improve people's outcomes long term.
Okay, are you near the end, Dr. Azmi now?
Oh, yeah, a couple more slides, sorry. Okay, so this is the droplet study, very similarly, looked at total diet replacement versus usual care. So 10 kilograms loss and those on total diet replacement compared to normal care. So we know that bariatric surgery can cause diabetes remission when done in the right patient. So this is not for everybody. Nice guidelines say a BMI above 35 in somebody with diabetes or above 40 with no comorbidities. However, they need to be worked up for in a tier 3 service and be the right patient so that they don't have sort of issues later on. But this basically, I'm going to quickly go over this. This shows that the top line is your control group versus the intervention group, that with bariatric surgery, there's an improvement in HbA1c, fasting plasma glucose, less diabetes medications, and improvement in BMI. What are the longer term outcomes of bariatric surgery and weight loss? So this is the Swedish obesity study that looked over 18 years. And basically, this is the control group and this is surgery group. And there's less fatal cardiovascular events and major cardiovascular events in the weight loss group post-bariatric surgery, showing that these effects are long-standing. I'm going to quickly talk about one study that I've been involved in. My interest in microvascular complications, and we've been looking at nerve damage. And neuropathy classically is a very debilitating condition and classically thought to be progressive. However, we looked at patients post-bariatric surgery and found that the nerves can actually regenerate in both patients with diabetes and without diabetes. And I could talk about this for like an hour, but I'm going to sort of give you 1 minute looking at these images here. This is looking at the nerves on the cornea of the eye, and we can see this is a patient, obese patient, and this is somebody, a control. There's fewer nerves, and this is them at 12 months where their nerve have actually improved. So in conclusion, the rise in diabetes and obesity is significant. It significantly impacts on patients' quality of life and reduces life expectancy. It will continue to place a burden on healthcare. Its BMI is a powerful predictor of type 2 diabetes, cardiovascular mortality, and morbidity. We need to identify patients and appropriate management initiated, and we should focus on weight loss where possible, as this is paramount. So thank you very much.
Thanks, Dr. Azmi. Just a few questions. Where does the role of the sugar tax, would you say, come into all of this?
The sugar tax. Right, so the sugar tax, so this was a tax that's been added on to like soft drinks and things. To initiate, started a few years ago. It's got its benefits in the sense that I think the main aim of this was to drive companies to improve their products so that they don't have as much sugar in them, and basically raise awareness of the fact that how much sugar there actually is in a lot of these products like Coke and other sort of sugary things. So I think this has hopefully raised it, and there has been figures to show that this has actually been successful, and there has been a lot of the companies have actually improved their products so that people who will still go on to buy them actually don't have as much of the sort of adverse effects, I suppose, of having too much sugar.
Excellent. And just one final question before we move on. There's a question here to do with dementia and BMI. Are you able to speak about that at all?
Dementia and BMI.
Is there any relationship that you've seen in your practice?
So I've not seen any sort of actual proper, I'm not aware of any studies. However, as Dr. Leroy just mentioned earlier, it is a risk factor for the development of dementia with regards to all metabolic diseases like hyperlipidemia, hypertension, hyperglycemia. These will ultimately, these need to be treated to ultimately sort of improve brain health overall. So there is a relationship there, most likely, and this obviously needs to be looked into in greater detail.
Thank you, Dr. Azmi. In the interest of time, we'll move on, but I know you're staying so we can ask further questions in the Q&A in about an hour's time. Thank you so much.
Cool. Thank you.
Right, so our next guest is Dr. Mohammed Munavvar, who's the current president of the British Thoracic Society. He's a consultant chest physician at Lancashire Teaching Hospital in Preston, amassing around 2 decades of experience. He is a regional speciality advisor, member of the Royal College of Physicians of London, and is also the clinical director of respiratory medicine. So over to you, Dr. Munavvar.
Thank you very much, Fahim. Can you hear me clearly?
Absolutely fine, Dr. Munavvar.
Perfect. Thank you so much for inviting me, Fahim, Mehran, and everybody involved. It's such a pleasure to be here. The topic given to me is lung cancer in COVID-19 times. Lung cancer itself is a massive topic, lots of exciting developments in the last few years. And normally this topic will take about 10 hours to discuss and do any justification, but I'm going to summarize it in a matter of 10 minutes. So only summary, just some headlines you're going to get. So you're going to have to focus very hard while I try and get through this topic. So moving to a brief introduction, first of all, lung cancer and COVID times. You know, COVID, as such, everybody knows, has been wreaking havoc around the world, marching relentlessly, leaving a trail of devastation, as you know very well. This is figures from last night, showing that more than 37 million people have been affected and more than 1 million have sadly succumbed to the illness. Coming to UK, there are more than 500,000 cases and more than 42,000 deaths. And the number of cases is going up and number of deaths as well. And COVID, as you know, does not respect royalty or indeed position. Several other leaders have also been affected by the condition. Moving to, one second, it seems to get stuck for some reason. Moving to lung cancer. Lung cancer is amongst the most commonly diagnosed cancers in the world. In the UK, the figures show that breast cancer is the most common condition, followed by lung and colon very close to each other, and prostate in males. But when it comes to mortality, lung cancer is the biggest cause of cancer death, and more than 35,000 people a year die from lung cancer. And if you combine mortality from breast cancer, prostate, bladder cancer, and leukemia, still lung cancer deaths are greater than all of those put together. And every 15 minutes, a person dies of lung cancer. So by the time we finish this webinar, sadly, 8 people would have lost their lives due to lung cancer. And the sad thing is, 1 in 10 people will die within a month of diagnosis. So it's a terrible illness, one of the worst that anybody can get a diagnosis with. And the cure rate, that is more than 5-year survival, is only about 10%. Despite all this, there is no screening program currently, but there have been some advances with the use of low-dose chest CT scan, and watch the space because it is going to come in, I think, as part of a screening program in this country, as has been implemented in some other parts of the world. What we can do effectively, though, is to get people to quit smoking. This is the single most important intervention which can make a massive difference to lung cancer incidence and outcome in the long term. And a number of approaches have been taken to try and people to get quit smoking. Still a lot more needs to be done from a public health point of view to initiate measures to support people to be able to quit smoking, because the single most important causative factor for lung cancer is smoking. A number of other things, initiatives have been tried as well. I brought this in because it's in there's some connection to COVID, as I'll show you in a minute. About 8 years ago, a team from Tübingen and Stuttgart in Germany showed that they could train 4 domestic dogs over a period of few weeks. There was 2 German shepherds, 1 Australian shepherd, and a Labrador retriever. They trained them to be able to pick up the scent of from the breath samples of cancer patients, and they could separate it from those in healthy volunteers and those with COPD with a sensitivity of 71% and specificity of 93%. This looked very promising, and a lot of work is being done from this point of view. Following on from this, recently I read an article where dogs could potentially be used to sniff out coronavirus infections. 8 dogs from Germany's armed forces were trained within a week to accurately identify the virus with a 94% success rate, according to a University of Veterinary Medicine study from Hanover. And this was tried out in the saliva of 1,000 healthy and infected people. And potentially, this could help us identify people at airports, border crossings, sporting events, etc. But simply because canines, dogs, have more than 1,000 times as good a sensitivity when it comes to smell as humans. The caveat, though, is that they should be able to differentiate COVID samples from other diseases like influenza. That's just out of interest. I thought I'll put that in. The next bit is to look at actually what happens in lung cancer. So, going on to what happens in patients who are referred to as with lung cancer, generally in the UK, they come through the 2-week rule pathway, usually either because they have an abnormal chest X-ray or they have another symptoms of red flag symptoms such as hemoptysis. So what happens with these patients? They usually undergo a CT scan. If they have the fitness is very good and they have no comorbidities, then they go on to have a PET CT scan, and then usually the most important investigation is the use of bronchoscopy and EBUS DBNA. EBUS is endobronchial ultrasound, which is a critical investigation using this particular development in the last 15 years, where an endobronchial ultrasound probe has been introduced into a bronchoscope, and there's a side channel through which a needle can be passed into the sample to obtain samples. Besides usual measures of taking biopsies, this particular technique can be used to sample all the areas around the tracheobronchial tree. This is both for diagnosis as well as staging purposes. So this is a massive development. Fahim, is it clear so far? Can you hear me?
Yes, it's clear, Dr. Munavvar.
Absolutely fine. 5 minutes to go.
Okay, super. So, however, there are peripheral lung lesions. This is central lung lesions that I've spoken about with the EBUS, but there are peripheral lung lesions. These are deep inside the lung, and they are quite difficult to access because once you get into the lung, the bronchial tree divides and subdivides and then leads on to the periphery of the lung, which is very close to the pleura, and it's very difficult to get to with the usual techniques that we have. So we use something called navigation bronchoscopy, and we use some new tools, including something called mini probe. This is called radial EBUS mini probe. Using this technique, we're able to get into the tracheobronchial tree guided by the CT scan appearances, guided by a number of new innovative tools, and thus access the periphery and obtain samples, because this is what's going to make a difference in the management of lung cancer. Because if you pick up small lesions in the periphery, you can take them out potentially, as I'll show you in a minute, and thereby achieve what is ideal, which is cure. That's more than 5-year survival following a diagnosis of lung cancer. More recently, robot-associated bronchoscopy has also come into use. This is a mini probe bronchoscopy being performed, just to give you an idea, but that's for another day. So if I were to summarize the management of lung cancer today, lung cancer, we try to make an accurate diagnosis, not just about the diagnosis of cancer, not just about subtype, but about the mutation status, what is called PD-L1 status. So a number of molecular typing bits also need to be done. After that, if the patient is fit and well, the best approach is surgery. If you cannot perform surgery for whatever reason, then chemotherapy plus or minus one of these targeted therapies. These are called tyrosine kinase inhibitors, PD-L1 or immunotherapy, and so on. So number of options are available, which we did not have previously. We have always had external beam radiotherapy for a select few patients. We now also have endobronchial radiotherapy, and more recently, what is called stereotactic radiotherapy, which is very focused radiotherapy, avoiding damage to the surrounding structures. So in short, surgery is the most important thing that we consider in our multidisciplinary team meetings, then chemotherapy, then tyrosine kinase inhibitors, immunotherapy, radiotherapy of different types, then interventional bronchoscopic techniques, such as use of laser type argon plasma coagulation, placement of stents, and finally, not to forget, most importantly, where you cannot achieve cure, effective palliative care. That is, best supportive care and even end-of-life care need to be planned in these patients. So what has been the effect of COVID with all these patients? Now, our lung cancer patients who come to our unit go through what is called lung investigation day, a fast-track process by which we try to do at the very first assessment as many things as possible, including CT scan, lung function tests, etc., and then put them through the diagnostic meeting, and then plan one single investigation, which will give us both a diagnosis as well as stage and enough material to carry out all those molecular subtyping things that I have mentioned in my previous slide. So finally, after doing all this, we would go on to treatment. However, COVID has come and interfered with this because smoking has increased the risk of COVID. Smoking-related damage has increased the mortality and morbidity related to COVID. And lung cancer overall, the management has been affected by COVID directly or indirectly. This has been shown also in various other cancers where the reporting of patients to the hospital has gone down and the diagnosis of cancers has gone down as well progressively. Why is that important? Because if the diagnosis is delayed in cancer, as has been shown in this particular study, every time you delay by a week, the chances of survival are reduced by 1.7%. So every week's delay counts, and therefore time is of the essence to get the diagnosis right in these patients and achieve a cure wherever possible. So here is another depiction of what happens. If your diagnosis is made at an early stage, there's a 60% chance of cure. And if it's diagnosed at a late stage, there's a less than 1% chance of cure. So there's a great deal of variation caused by the delay in the diagnosis. So in conclusion, lung cancer is an aggressive disease, without a doubt, with high morbidity and mortality. Early accurate diagnosis and precise staging are absolutely essential to improve chances of survival. Therefore, we need to confirm the diagnosis include subtyping and mutation typing to plan personalized targeted therapy. There are numerous advances in this field. I've mentioned a few: endobronchial ultrasound, navigation, immunotherapy, stereotactic radiotherapy, tyrosine kinase inhibitors. COVID, unfortunately, has had an impact, and that needs to be addressed. We need a multidisciplinary approach for optimal treatment. And in advanced incurable disease, we should not forget the importance of proactive palliation in these patients, including end-of-life care. When I said that COVID has affected everything in our practice, this is what we looked like before with a larger team, and this is what we look like now in the era of COVID. A smaller team to minimize exposure, modified practice so that we do not delay diagnosis. In many parts of the world, this is how bronchoscopy is being performed. In our center, fortunately, we have access to theater facility at least once a week for the full day, and therefore we're able to put patients through the diagnosis without delay, get the diagnostic procedures, at the same time minimize exposure to the staff and everybody else while performing the procedure. We have a number of innovative techniques available to us to try and get the diagnosis and plan personalized targeted therapy. And this involves a huge multidisciplinary effort, and that is what's important to achieve the best outcomes in patients with lung cancer. Thank you very much indeed for your attention.
Thanks, Dr. Munavvar. There's obviously a lot of questions come through, so we'll just take a couple of them and then deal perhaps with the rest in the Q&A. Are there any links with vaping and lung cancer, or any guidelines to do with in primary care to discuss the risks of vaping?
Oh, very good question. Not enough scientific evidence at the moment. Vaping, we've seen the effects on lung injury, but directly we do not have enough evidence. It's early days to draw a correlation with lung cancer per se. So difficult one, but watch the space. I wouldn't be surprised if there is a link.
Excellent. Just one other question for now. There's been a delay perhaps in some of the investigations that we've seen because of COVID. And has that impacted, do you think, on mortality? So the question is to actually do with the delay in treatment due to fewer people approaching services for early symptoms. Has that led to an increased number in mortality?
Intuitively, probably yes. But in our center, what we've tried to do is to prioritize and try and manage all those patients with lung cancer through a different pathway. We have tried our very best to minimize delays when it comes to diagnosis. There has been some delay with regard to surgical procedures because of the need for self-isolation for a period of time. Equally, there has been some delay when it comes to chemotherapy because of the potential interaction between COVID and the chemotherapeutic agents. So some delays are inevitable, but we must try to our very best to minimize delays. So that's what we've done when it comes to the diagnostic side. However, patients have reported a bit late. They've delayed presenting themselves. So that's something that we need to raise awareness about and encourage them to get in touch for, as we say, business as usual when it comes to lung cancer.
Thank you so much, Dr. Munavvar, obviously the president of BTS, the British Thoracic Society. So it's a real pleasure and honor that you've graced our occasion. I'd be very pleased if you could stay for the remainder of the web meeting, and perhaps you may even be able to speak a little bit about BTS and your role near the end of the meeting, as well as further questions. Is that okay with you?
Entirely my pleasure, Fahim. Thank you so much for the kind invitation. It's an honor.
Excellent. Mehran, if we can introduce the next presenter, please.
Yes, so our next presenter is Dr. Syed Raza, who I do know well from previous, broadcasting and educational activities that he's very much involved in, because he is also the founder of Raza Heart Foundation that looks at educating and increasing awareness on various health-related topics. He is a consultant cardiologist that applies his trade in Bahrain at the moment, but he did graduate from Aligarh University in India in 1993. He's also a fellow of the Royal College of Physicians of Edinburgh, and he's also a permanent review author for abstracts for European Society of Cardiology annual Congress. So he brings a wealth of experience, and I look forward to his presentation. So Dr. Raza, over to you.
Thank you very much, Dr. Mehran, for the very kind introduction. And thank you also for inviting me to this scientific platform. Now, first of all, can you hear me?
Yes, we can, yeah.
Okay, so a very good evening from Bahrain. In next 10 minutes or so, I'm going to give you an overview as to how heart is involved in COVID-19. Now, with the spread of the coronavirus, it was known to us that lung was the primary organ that was involved. But soon we came to know, and it was quite evident, that heart indeed was in the heart of the corona pandemic as well. World Health Organization released the data that showed that the patients who had underlying comorbid conditions did have a much higher mortality compared to those who did not have the comorbid conditions. And those who had the cardiovascular disease as a comorbid condition, they had a risk of being admitted to the hospital about 5 times, and they had the risk of death that was almost 10 times compared to those who did not have underlying comorbid conditions. Now, a lot of papers emerged from trials and researches that flooded the scientific arena, and that showed there was a clear and a distinct link, but a definite link of COVID-19 with the heart. Now, this slide shows that the pathophysiology of COVID-19 as to how it affects the heart is not only multifactorial, but it is also quite complex. But I've tried to just summarize this on a single slide. Now, we all know that the COVID-19 progresses through three phases. There's phase 1, phase 2, and phase 3. And it is the third phase, which is the hyperinflammatory phase, where there'll be rise in the cytokines such as interleukin 1, interleukin 6, tumor necrosis factor alpha, and so on. So what it leads to, we know, is a cytokine storm. Now, when these inflammatory markers rise, they also cause inflammation and breakdown of the atherosclerotic plaque in the coronary artery. And this will lead to rupture of the atherosclerotic plaque, and this will shut off the blood supply and oxygen supply to the heart muscle, leading to what we call myocardial infarction. And this, by definition, is type 1 myocardial infarction, where the atherosclerotic plaque is ruptured. Now, in addition, the lung being the primary organ that is involved when there's pneumonia or ARDS, this leads to significant hypoxemia. And in addition, when there is cardiovascular instability, that will lead to supply-demand mismatch. And this again will lead to lack of blood supply or oxygen to the heart muscle, leading to its damage. And this will cause myocardial infarction, or this is called, by definition, type 2 myocardial infarction, because there is no rupture of the atherosclerotic plaque here. Now, we also know by now that the SARS-CoV-2 virus attacks the cardiac myocytes directly, causing its inflammation, and that's what we call myocarditis. Now, in addition, we also know that it also leads to changes in the coagulant factors that would lead to disseminated intravascular coagulation, and this will put anybody at risk of bleeding, but primarily it leads to more of thromboembolism, and more so venous thromboembolism than arterial thromboembolism. Now, further complications that can develop are acute decompensation of cardiac function, leading to acute heart failure and also cardiogenic shock. Now, once the heart muscle is ischemic or it is inflamed, it becomes a perfect substrate to cause arrhythmia. Now, arrhythmias that we have seen in COVID heart patients, they range from atrial to ventricular arrhythmia, and this could be brady and tachyarrhythmias as well. Now, this is a slide that has been devised by myself. You'll not find it in any textbook on any web page. Now, essentially, it is to increase your understanding as to how you can differentiate between myocarditis and myocardial infarction. Now, as you all know, that chest pain is the commonest symptom that any patient presents to our emergency door or through the cardiology outpatient clinic. Now, these patients may present with some ECG changes, as well as rise in the cardiac marker, which we all know as is troponin. Now, this to make a conclusive diagnosis, and it is very important to make the diagnosis from the very beginning, because the whole management as well as the prognosis will rest as to whether the patient has myocarditis or myocardial infarction. Now, to make a confirmatory diagnosis of myocardial infarction, we need to perform a catheter coronary angiogram. And to make a confirmatory diagnosis of myocarditis, we need to do an endomyocardial biopsy. But short of these, we may rely on cardiovascular imaging such as echocardiogram, which is readily available. And we may also take help of cardiac CT scan to look at the coronary arteries non-invasively. But the best cardiovascular imaging modality that we can use to differentiate the two is cardiac MRI using late gadolinium enhancement. Now, but the fact of the matter is that when these patients are quite sick, lying on ICU or CSU bed, to get these investigations are not only difficult, but they can also be sometimes impossible. So under these circumstances, we are going to rely just on two things. One is to make a good initial clinical assessment, and second is your sound clinical judgment, because the whole management plan will rest on these two things from here on. Now, contrary to what we have seen and what we believed initially, that COVID-19 caused heart issues and mortality, especially in the older individuals who were 60 or 65 and above, and those who had comorbid conditions. But now we have recognized that the young and healthy individuals are not spared from COVID-19, and they can die as well, and they can die sometimes suddenly. Now, we do not know the exact cause, but there are some theories that have been put forward, and some of them I've listed here. Now, genetic predisposition. Now we know by some research, and they have given some findings that there can be some genetic feature that may increase the expression of gene ACE enzyme 2 that will lead to increase in the susceptibility of some young healthy individuals to have COVID-19. In addition, there are some genetic conditions that will lead, or the patient may already have lung condition like alpha-1 antitrypsin deficiency, cystic fibrosis, and some genetically predisposed congenital heart disease put these young and healthy individuals at risk of COVID-19 as well. Now, these patients may have childhood asthma, they may be long-term smoker, they may also have poor immunity to fight infection, and also they may be carrying high viral load from the very beginning. Now, how these patients die? Now, they may die because of a few conditions that I mentioned here. One is the acute fulminant myocarditis. Now, acute fulminant myocarditis is the severest kind of myocarditis that we know of that can lead to sudden deterioration in cardiac function and can also predispose to malignant arrhythmia like polymorphic ventricular tachycardia and ventricular fibrillation that can lead to sudden cardiac arrest and sudden cardiac death. Now, we know that COVID-19 is a prothrombotic state, and it does not only cause thrombosis in the coronary arteries, but it also causes thrombosis in the cerebral vessels, leading to stroke in young and healthy individuals. And this can also lead to fatal pulmonary embolism that can kill these patients. Now, these two medicines, I'm sure you have heard, they have been a hot topic at one point. They gained popularity, particularly hydroxychloroquine, and this popularity was gained from some limited retrospective observational studies from China, mainly Italy and Belgium. Now, soon these two medicines, they became unpopular, and it was primarily because it was found that they cause cardiac adverse effect. Now, the problem was that these medicines, although we knew for a long time, but these medicines were being used in COVID-19 patients for treatment. And these, what they do is they increase the QT interval. Now, what is QT interval? It is the beginning of the Q wave to the end of T wave. This is shown on an ECG, a snapshot of a 12-lead ECG. And from the beginning of the Q wave till the end of the T wave is the QT interval. And we correct that QT interval depending on the heart rate. Now, essentially, the QT interval, normal QT interval would be less than 440 milliseconds in male and less than 460 milliseconds in female. Now, when this corrected QT interval prolongs beyond 500 milliseconds, it predisposes to what we call torsades de pointes or polymorphic ventricular tachycardia. The example is shown here, where the QRS morphology, they are different from each other, and there is changing axis points. Now, very recently, it is in August this year, a systematic review was published in the Journal of Clinical Microbiology and Infection journal, and that showed that the patients who received hydroxychloroquine indeed had a higher 28-day mortality compared to those who received usual care. Now, similarly, as you can see here on this Kaplan-Meier survival curve, that the patients who received hydroxychloroquine, that is shown in green here, had the worst survival, and this was followed by patients who received hydroxychloroquine plus azithromycin. And now you may ask why this. This is because I think because that these patients had some, azithromycin has got some antiviral property, as well as probably it helped in treating the secondary bacterial infection. But the graph shown in red here, of course, shows those patients or represents those patients who did not receive any of these two treatments, and the survival was much better in them. Now, there are another drugs which I need to mention here are ACE inhibitors and angiotensin 2 receptor blockers. Now, these are the drugs you all may know that these are used very commonly for hypertension, heart failure, and also chronic kidney disease. Now, patients became apprehensive, they were scared, and a lot of them, they started to call cardiologists and physicians and asked whether these drugs will be appropriate or safe for them to continue. So there was a lot of controversies and a lot of confusion around these drugs. And finally, and thankfully, the first randomized trial data came, this came from BRACE Corona trial, and the data was only recently discussed at a hotline session at European Society Cardiology Congress on the 1st of September. And this clearly showed that the ACE inhibitor and angiotensin receptor blocker were absolutely safe to continue, not only in COVID-19 patients, but also who were at risk of developing COVID-19, meaning thereby the patients who had other comorbid conditions, if they had cardiovascular disease, hypertension or diabetes, they were also safe to continue both the medicines. So in conclusion, ladies and gentlemen, cardiovascular involvement in COVID-19 is well known now, and it does lead to increase in significant mortality. And sometimes it can also be a cause for sudden death, and it can be a cause for sudden cardiac death. I have already alluded to you that the pathophysiology as to how heart is involved in COVID-19 is not only multifactorial, but it is also quite complex. There's no special treatment that we can offer to the patients who have COVID, who has got heart involvement due to COVID-19, and the treatment is mainly supportive, and the same treatment we follow, and these are the guideline-directed therapy as we do for the individuals. So I thank you for your listening and for your patience.
Thank you, Dr. Raza. Just got one question for you, if you can take that now, please. And it's to do with long COVID. The question is there any evidence of myocardial damage contributing to long COVID? Before you answer that, just for listeners and viewers who aren't aware, for most people, COVID-19 is a brief and mild disease, but some are left struggling with symptoms, including lasting fatigue, persistent pain, and breathlessness for months. And that condition is known as long COVID. Could you answer the question, please, Dr. Raza?
So if I understood your question correct, Dr. Javed, so now just interrupt me if I'm not giving you the right answer. Now the myocarditis in any condition, any viral disease or for any other predisposing etiology, now myocarditis can present in a variety of fashion. Now depending on what type of myocarditis we are talking about. Now one I showed is the acute fulminant myocarditis, which is certainly an acute and a very serious condition. Now, what has been seen in COVID particularly that these patients, they present with very vague symptoms. Now, if I understood your question right, now we are seeing now there can be late sequelae following myocarditis secondary to COVID-19. Now, I'll just give you a very quick example. There's a recent study been done in Germany where they have screened 100 patients who had probably had some kind of myocarditis. Now, these patients were discharged from the hospital, and 2 months down the line, they had cardiac MRI. Now, you wouldn't believe that at least 60% had some kind of damage done to their heart with very mild symptoms that were suggestive of myocarditis. So down the line, we feel that we might see a lot of patients who may have actually suffered myocarditis during the course of their illness, and that will also lead to increase in the prevalence of non-ischemic dilated cardiomyopathy.
Thank you, Dr. Raza, and I'll hand over to Mehran to introduce our next presenter. Thank you.
Yes, thank you, Dr. Raza. And it'd be great if you do stay on for the Q&A, because I'm sure there will be further questions being asked. So our next guest is Dr. Ahsan Akpan. So he is a consultant geriatrician at Liverpool Hospital and Mersey Care. He's also the chair for the Mersey British Geriatric Society. He's also a visiting professor and assistant professor. But the key element of Dr. Akpan is he's very much an academic geriatrician in the Northwest, with a focus on interdisciplinary clinical practice, teaching and research. He's very much involved in innovation and looking at population health approaches. He's very much active on Twitter, so please do follow him. I certainly do, and he does keep me informed and entertained. So over to you, Dr. Akpan.
Thank you very much for the introduction. And yes, please, the most important thing from this talk today is please follow me on Twitter. So there you go. Right. So I'm going to just pull out a few themes for you about COVID and older people. I'm not going to go into much detail, but maybe some take-home messages that I have picked up over the last few months that I would like to share with all of you. And of course, there are lots of gray areas, lots of uncertainty. So we'll touch on that. And I know I've got like 9 minutes, so don't worry, I'll be done in 8. So we do know that this is very common in people over the age of 50, and the older you get, the commoner it is. If you have associated, the more chronic conditions you have, then the risk goes higher. And certainly if you have moderate to severe frailty, then your risk escalates. And we do know that depending on which ethnic background you come from, again, the risk goes up. So you can see that some people can have all of this, and therefore they can become very sick. Now, not only that, when older people do get this, they do tend to have a more severe form of the infection, and they have a higher mortality. So these are things just to be aware of in the background. Now, we do know what the common presentations are, but again, I would like to pull out some interesting things we've noticed in older people over the last few months, mainly from quick, rapid, systematic reviews that other colleagues have kindly done. So one thing we're picking up is that a lot of older people can present with acute confusion, delirium, which that's all I'll say about it, because I've got my eminent colleague who's going to tell you all about delirium. So just be aware that if an older person presents with delirium in the setting of this pandemic now, we should also be thinking of excluding COVID. Of course, we have the dry cough, the breathlessness, and the hypoxia. But the other thing that is coming across is that, of course, older people, especially in care homes, can be asymptomatic, and therefore they will be transmitting it without knowing. So that's one of our key challenges in care homes. The other thing that I have also come across is increasingly we're being referred patients. And it's not like we haven't been referred before, but we get people being referred because they feel tired and exhausted. And in the last 2 or 3 weeks, I've had 1 or 2 cases where people just feel that their breathlessness has not resolved and they feel exhausted. I mean, people who were biking, who were running marathons, and I'm talking about people who are older, they're 70 plus, and they were very active, and now they can't leave their house. So it's interesting that we're beginning to see some long-term complications, and we still don't fully understand the trajectory of this disease. One of the things that we obviously do is we want to check for hypoxia, because this is an early sign which we can try and address early. And this is has been a key challenge for our older patients who are resident in care homes. And in the last few months, there's been a national drive to try and supply pulse oximeters to most care homes. I know that up here in the Northwest, and especially in the Liverpool area, we recently had a presentation from a national lead on this, and the government has got a stock of pulse oximeters, and we've been trying to get them for our care homes. We know that the lymphocyte count tends to be low, which applies to everybody. But again, just pulling out some key themes here, and the CRP can be elevated. Now, one thing that we also have come across a lot is that when we test for the COVID, it can be negative, even though they are the clinical symptom signs. And when we do the investigations, they point very much to COVID. So we do tend to treat them as COVID. And usually when we repeat the test again, it then becomes positive. I'm not a chest physician, but I thought I'll just show what a chest X-ray in COVID might look like. So the one on the top is the abnormal one, where we talk about the bilateral ground glass opacification tends to be ill-defined. And the one below is what a normal chest X-ray would look like. And of course, we do proceed to CT. And again, up above is what an abnormal CT in COVID would look like, where you have the ground glass opacity, and below is what a normal CT would look like. So these are some of the common investigations we would do. And interestingly, as I said, this can all be there and the COVID test would be negative, but we'll still treat the patient as having one. These are the commoner causes of death, and it applies to older people too. Acute kidney injury, liver dysfunction, respiratory failure, pneumonia, very common, sepsis, and then acute respiratory distress syndrome. So at the beginning of this pandemic, as you know, we're all uncertain about what to do, but things are becoming clearer and clearer now. So I cover a COVID ward now, and usually when I go on there, half of the patients are on oxygen, they're on dexamethasone, they are on fluids, they are receiving antibiotics, and if they are particularly ill, they might get the antiviral drug. So these are drugs that I was not very familiar with, but again, over the last few months, I've become quite familiar with all of these things. And I feel like I'm doing a rotation in respiratory medicine. I've learned a bit more and updated myself on the indications for non-invasive ventilation. My colleagues, both from ITU and respiratory medicine, have always been very happy to re-educate me about this, and obviously who we can refer to ITU. So the key thing with our older patients who have severe frailty or who, for other reasons, may not benefit from this presents some unique challenges, because we then have to, apart from giving the initial treatment, it is incumbent upon us and very important that we discuss how far we would go with treatment, what would be beneficial, what would not be, and we have to discuss ceilings of treatment. So it's just part and parcel of our clinical management plan now that all of this is done. Now, as a community geriatrician, most of my time is spent outside of the hospital, and we've been supporting our local care homes a lot. And this is where we've been having discussions to identify people who would be escalated to have all the necessary treatment, including being on a ventilator, but also importantly, identifying those, even when there was no COVID, who would not benefit from aggressive treatment, because we recognize that that will not make a difference. So we're making sure that we're doing all of that and having those very sensitive and supportive discussions with older people, their carers and their relatives, and trying to get us all ready and set if unfortunately we head into a second wave, as it looks very likely. You may also be aware that nationally, there is a drive to set up what is called COVID-19 virtual wards, and most of this tends to be led by the acute physicians or the respiratory physicians. And a few weeks ago, the national lead on this presented here up in the Northwest, and I know in Manchester, they've got something up and running. And I think in Liverpool soon, we're going to have something similar, again, to try and identify people who we would be able to treat and manage with oxygen and maybe dexamethasone outside of hospital, but there will be clear pathways to escalate them into hospital if necessary. This is all just part of trying to manage capacity in the system. So I did mention that there are some gray areas, and this is not surprising. So one of the things is about how do we triage older people appropriately? How do we make appropriate prognosis? How do we decide who should have everything thrown at them and who are the ones that maybe will not benefit? So while in some cases it might be very clear, there are still individuals who present and we're not quite sure what to do. There is a lot of work still going on, lots of research going on to try and improve this and provide more evidence. And also we're looking at population health measures. So in summary, I've tried to pull out some key things about older people. It's commoner in those who have more frailty, those who have more chronic conditions. There are certain ways that older people might present that might be unusual, but we need to think about that. And in terms of management, the key thing is to identify and have a discussion about ceilings of treatment where appropriate. You don't want to leave that until there's a crisis or when the med team is called out. So I will end there because I know there will be opportunities for questions, and I very much love the questions because that's when I also learn. So thank you very much.
Thank you, Dr. Akpan. I can confirm that at least one of the people watching and listening today has added you on Twitter, so I can give you the good news on that. In terms of questions, though, as you said, we will speak more at the end, but I do want to just take one before we move on to the next speaker, and that's to do with this concept of social isolation in the elderly people now. We know that the elderly are more vulnerable to COVID-19, they have a higher risk of mortality, morbidity, but at the same time, they've been asked to perhaps do shielding, stay at home, and it's ongoing, and it can really have a big effect on their mental health. What do you say to the older people who might be watching today as to how they can actually cope with this second wave?
Okay. So again, at the very beginning, we really did not know what we're dealing with. So I think it was appropriate to try and protect people, especially as we did not have knowledge about this virus. But now we know a bit more, or a lot more, and the advice that we're giving, and we're not actually shielding now, the shielding has been paused, is that you have those individual discussions with the person who is the most appropriate clinician looking after you. So it could be your GP, but it might be your secondary care clinician, depending on your underlying condition. And those discussions will be had. And I think my advice is then people should be allowed to make those decisions for themselves, you know. So as I've said, if you're above 75, you've got moderate or severe frailty, you've got lots of chronic medical conditions and possibly some other things, then you're at high risk. Now, if that information is shared with you and you do decide that you will go out, wear a face mask, keep a social distance, try and avoid large gatherings. So maybe go to the park where you might be the only, there won't be that much crowding. Then you're reducing your risk. So those are the sort of things, but you may not want to go into a pub, you may not want to go to a restaurant, you may not want to have many people visiting. So yes, we don't advocate that people should be quarantined like they did before, because we know what that can do psychologically and also physically. So we're trying to encourage people to have appropriate discussions, and even when they do go out, to still take those protective measures to protect themselves and others.
Thank you, Dr. Akpan. I'll move back to Mehran to introduce our next speaker.
Thank you, Faheem, and thank you, Dr. Akpan. Our next presenter is Dr. Emma Vardy, who's a consultant geriatrician at Salford Royal Hospital, who I do know very well. She is the clinical dementia lead at the hospital and also for the Greater Manchester Strategic Clinical Network. She does have a huge interest in delirium and dementia, quality improvement, digitalization, as well as research. She is also the chair for the British Geriatric Society Dementia and Related Disorders Special Interest Group, and as well as being the clinical lead for the NIH Greater Manchester Aging Theme Clinical Lead. So thank you again, Dr. Vardy. Over to you to start your presentation.
Oh, thank you for the introduction, and lovely to be with you all, and such fantastic speakers so far. I'm just checking, can you see my slides and hear me okay?
Absolutely fine.
Great. So my title is the What and the Why of Delirium, and I've added on a little bit about the how, and all in 10 minutes, so I'll keep it concise. So what is delirium, first of all? What are we talking about? Well, it has a number of features. It's acute, so it's new in onset, so it's different to dementia. In that it's not a chronic condition, it's something when somebody becomes newly confused. The confusion can fluctuate, so that can be from day to day or between the morning and the evening. The other feature is that the person can have poor concentration, so they can't keep track of, for example, conversations, or if they're asked to do something, they might start and then lose their concentration. Disorganized thinking is a little bit more difficult to describe, and it's when The person's thinking is, for want of a better word, a bit muddled, where the person will flit from topic to topic. And delirium can also present with the person being more sleepy and drowsy than usual. So it's described in two ways: the hyperactive type, which is where the person's perhaps more agitated, they might have hallucinations as part of their delirium, or the hypoactive type, where the person is more drowsy. It can sometimes be a little easier to miss the hypoactive type, and it can be also misdiagnosed as depression in some people. It's really quite a distressing condition for people to experience. And so I'd encourage you, if you're interested, to look up a YouTube film that we made at Salford and with the Strategic Network. It's Enid's story, and this it's available if you put in Salford Delirium and digital, then you will come up with this film. And this is Dale, her daughter, also explaining what it was like to see her mum with delirium. And it gives you a really good insight as to what it's like. Why is it important? Well, as I've explained, it's really distressing for people who experience it, for their families to see the person with delirium, and also for the staff who are caring for them. It means that people are more likely to be admitted to hospital, and if they are admitted, they're more likely to stay longer in hospital. People, when they have delirium, are at higher risk of other harms, such as falling over or pressure ulcers. It's life-threatening. So this is quite a startling statistic, in that 1 in 5 people who experience delirium will not survive, will be dead a month after the delirium. And that's a similar mortality rate, and possibly higher actually, than myocardial infarction and sepsis. You're more likely, if you have a delirium, to go on to develop a dementia in the future. It's not an absolute certainty, but there is a link. And also, if a person has dementia, then if you have a delirium on top of that, you're more likely, the dementia is more likely to more rapidly deteriorate after a delirium. And you're also the person is also more likely to go into institutional care. And through speaking to people who experience a delirium and their carers, they want us to pick this up early. And it's also very common. So in the hospital, the often quoted figure is that 1 in 8 people in an inpatient bed in hospital will have a delirium at any one time. So who's most at risk? Well, older people, also, as I explained, people with dementia, people who are frailer, people who are sensory impairment, so poor eyesight or poor hearing, people who are on multiple medications, and certain medications can also precipitate delirium. And relevant to COVID are medications such as steroids, which have got a known link with precipitating delirium in some people. Also, if somebody's had a recent fracture, like broken their hip, or if they've had recent surgery, and also if they have severe illness. So although being older is a risk factor, if you are younger and you have a severe illness, there is a risk of a delirium. The causes can be easily remembered using this mnemonic: pinch me. So pain, infection, poor nutrition, constipation, poor oral intake, not eating and drinking as well. Also some medications I've explained, and environmental causes such as sleep disturbance, or in the hospital being moved from one ward to the other can cause it. Also, putting a catheter in can contribute to a delirium. So how do we detect it? Well, there's a really nice, simple tool called the 4AT, which was developed by my colleague, another geriatrician up in Edinburgh, Alistair McCulloch. And it's divided into a test of alertness, an AMT4, which means asking the person if they're aware of their age, their date of birth, where they are, what the current year is, their attention level, so whether they can recite the months of the year backwards and how far they get, or whether they can even attempt it at all, and that element of, is there a new change, is the person different to usual, and depending on how the person does in all of those different domains will give the person a score. And if they score 4 or more, that means a delirium is likely. So just to drill down a little bit further on how you make a diagnosis, well, the history is really important. Also, the person's vital signs. So assessing the person with their temperature, their blood pressure, pulse. Investigations can be divided into blood tests to help look for the cause. Also an ECG, because having a heart attack can precipitate delirium in some people. If there's evidence of infection, you might send off other samples such as blood cultures, or consider sending off a urine specimen. And the other type of test are looking at oxygen levels, and you might want to look at blood oxygen levels with a blood gas. And the other consideration is a CT head scan. And really that would be reserved for if the person has had a fall and a head injury, if they're on a blood thinning medication, such as warfarin or other blood thinning medications, then you would consider it urgently. And if there's any new neurology, so that means if the person has developed any weakness or reduced level of consciousness. Management is divided into non-pharmacological, so that means without using medication. So that would be reorientating the person, treating things like encouraging them to drink more, treating any constipation that they have, treating any underlying infection, and treating the underlying cause, including looking for pain. Also, if they had anything like retention of urine, you might need to treat that. And medications are really avoided because there's a little evidence for their effectiveness, and also they can make delirium worse. They really would only be considered if the person is very distressed or if they're at harm to themselves or others. So yes, medication would generally be something to avoid because of the evidence base and also the fact that it can cause further harm. But prevention is a really key area for delirium. So we know that we can prevent about 1/3 of delirium in the hospital setting, and many of those preventative factors are targeted around the causes that I described before. So reorientating the person, keeping the person mobile, encouraging them to eat and drink, reviewing medications, treating pain if there is any pain present, and promoting good sleep patterns. This is a campaign based in the UK around encouraging visits from family carers for the person when they're in hospital, to help reorientate them. And obviously with COVID and infection control, this has been more difficult to facilitate. So how do we improve the diagnosis of delirium? Picking it up is really important and will be the trigger for looking for the underlying cause and treating it. Well, we carried out a project in Salford, and it was based in A&E, and the aim was to screen everybody at risk of a delirium when they when they visited A&E, the emergency department. And so everybody 65 years and over was to be screened. And this just shows, just to summarise, the data that we collected showing that before the project, screening that particular patient group was quite low, but we introduced the assessment tools for delirium and the 4AT and a management bundle into the electronic health record. And that's depicted by that thick red line, and you can see that after that, assessment of that patient group for delirium really improved, and also regular educational sessions were really key to that as well. To mention the link with coronavirus and delirium, so I think many of us experts in older people's care, geriatricians and those working with older people, noticed quite early on that delirium seemed to be a key feature in older people who contracted coronavirus, and a number of groups and colleagues across the world started to collect data around that. And this is just, you can see there's one reference to a paper that used the app, one of the COVID apps, and looked for symptoms that were linked to COVID. and showed a link between delirium and coronavirus, and that it can be the only presenting symptom in some older people who contract COVID. And this was picked up by news, BBC News, coronavirus, delirium being a key symptom in frail older people. And Public Health England as a body also has amended their guidance and enhanced it by listing delirium as a potential symptom in older people and also people with cognitive impairment that should trigger a test for coronavirus. So in summary, delirium is common. It was common pre-COVID. It's also common now post the COVID pandemic. It's treatable and it's preventable. It's also, as I've hopefully shown, a patient safety issue in the fact that it can cause other harm such as falls, and education and the use of electronic patient records can enhance the diagnosis of delirium in the hospital setting. And just for interest, we're extending the project that we started in the hospital into the community, and as services are developing the community, partly fast-tracked because of the COVID pandemic, we've developed in Greater Manchester a community delirium toolkit, one of the pillars of which is detecting and also safely treating delirium in the community, and trying to treat cases where they can be safely managed at home and reducing unnecessary hospital admissions. So thank you very much.
Thanks, Dr.
Happy to
Vardy.
take any questions.
Yeah, just take a couple before we move on. The first one was, can we reduce the risk of a patient having delirium?
Yes, so the slide that I showed you around prevention, so it's really good clinical and nursing care. So trying to prevent some of the risk factors from developing. So orientating that person, particularly if they've got risk factors such as dementia, if they are in an unfamiliar environment, encouraging the person to maintain their fluid intake and to eat meals, preventing other precipitating factors such as treating any pain early, and also treating any constipation before it develops into a more significant problem. And the key thing is picking the delirium up early.
Excellent. And another one, delirium, as you are aware, is one contributor to hospital length of stay. Sometimes delirium can be a presenting feature of dementia. What is the cutoff period for a duration of a suspected delirium? For example, if a patient is in the hospital for 14 days when all identified precipitants have been identified and treated, but the patient is still confused, would that be delirium or an evolving dementia?
It can still be a delirium at 2 weeks. So there's two things worth noting. First of all, the Scottish sign guidelines, the guidance in those is that if the delirium features are still persisting at 6 weeks and the person that's probably more in the setting of when the person has been discharged home, that you should seek some review of those symptoms. The second is that there was some research carried out by a colleague called Tom Jackson, which was looking at the use of something called the IQ code, which is a questionnaire looking at features of dementia preceding the delirium, and showing that the IQ code could potentially be used to distinguish as to whether there might be a pre-existing dementia. But 2 weeks would be too early to make that diagnosis.
Thank you, Dr. Vardy, and I hope you can stay on for the Q&A at the end. Just for everyone listening and watching today, we are running a few minutes behind schedule, so we've got 2 more speakers. So if you could stay just after 7 p.m, and I understand if you're unable to do so. Okay, Mehran, over to you.
Thank you, Fahim. And our next guest is Mr. Ray Radford. He's an ophthalmology consultant in the northwest of England. He has performed thousands of cataract and eyelid operations. He is a trainer in both cataract and oculoplastic surgery with almost 2 decades of experience. He's also honorary senior lecturer at the University of Manchester in recognition of his contribution to undergraduate training. In addition to that, he has written and supervised numerous published articles in the field of ophthalmology. So, Dr. Ray Radford, over to you.
Thanks very much for the invite. Can you see the slides?
Yes, perfectly.
We're all working. Good. I've enjoyed this evening. It's been very interesting. Cataracts are obviously a common problem in the elderly population. And all the things I've heard this evening have been extremely relevant over the last 4 or 5 months. Some pretty pictures here of very dense lens opacities, white cataracts. And probably the biggest impact of the COVID has been that cataract surgery has been delayed. I'll touch on that again later on. But I have seen an increasing number of people presenting with white lens opacities, which we hadn't done so much of in the last few years. It's World Sight Day, just a few days ago. As it shows on the slides here, the biggest single contributing factor to blindness in the world is the presence of a cataract, almost half. Things are getting better, or were getting better, because world blindness has been reducing over the last 10 to 15 years. But I think 2020 really has put the kibosh on so much of what we've been trying to do. So here are some cataract figures. 2020 has been planned for a long time as this special day in the world of ophthalmology, because as you know, 2020 is considered very good vision. In the UK, we call it 666. But unfortunately, 2020's turned out not to be that case. But going back to this World Health Report, we already knew that cataract blindness was a huge thing, and blindness is characterized by having vision of less than 360. So on a Snellen chart, the top letter, the biggest letter, usually a T or something, be classed as 160, or 660, but you have to bring the chart closer to 3 meters. And if you can only still see the top letter, that's the only thing you can see, that's classed as 360. If you bring it to only 1 meter in front of the patient, that's 160. So 360 is being decided that was the term to say someone was blind. Oh, in the UK, we've stopped using that term because they're not actually blind as the layman understands it. If you have vision of 360, you still have vision. You're not blind, because to the layman, blindness means you can't see anything at all. So we now call it a visual impairment, which is a more accurate way to describe things. The other thing that has been happening, and we've been aware of, is the population are getting older. So whilst people aren't necessarily living a lot longer, more people are living longer. So we knew and expected from about 20 years ago that the people over 60 years of age would double. So it's estimated there was over 100 million eyes with cataract and visual acuity less than 660. But of course, over the last 20 years, population's gone up. And more importantly, people with vision less than 618, so that's seeing just less than halfway down a Snellen chart, are significantly visually impaired. So that's a line below driving standard. So probably 3 to 4 times as many elderly people are affected to that degree. And that was in 1998. So now we're talking anything up to 800 million people who are significantly visually impaired. So what are we doing about it? Well, across the world, cataract surgery rates will vary greatly. In North America and in Western Europe, we've got fairly high figures of how many cataract surgeries are done per million of population. In India, there's some big eye surgical units in India who get through vast numbers of cases. But in South America, in Eastern Europe, the numbers are much lower, and they may get to Africa, where there's a much reduced provision of all medical facilities, and we're down to very low rates of cataract surgery. And of course, that's in a population that's getting bigger all the time. So in the Western sphere, modern cataract surgery has changed a great deal. An operation that used to take 30, 40 minutes, and you had to stitch the eye, was associated with many problems, infection, bleeding complications, the iris, the color part of the eye coming out of the eye, all sorts of issues. In addition to that, a 3-month period in which the eye had to heal. That's how things were when I began 20 years ago. And things began to change as I started. But now, certainly in the West, modern cataract surgery, the average operation probably takes between 10 and 20 minutes. An experienced surgeon can be doing cataract surgery in 5 to 10 minutes. But modern cataract surgery in the West requires expensive equipment. So phacoemulsification is this little probe you can see on the picture, which basically goes in through a very small self-sealing incision and will hoover out the cataract. And then the lens is replaced, the natural lens is replaced with an artificial lens, as you can see top right, and will sit in the eye, as you can see bottom right. And it sits within the normal capsular bag that the original lens was in. So it's very secure and it won't fall out, which is a concern some patients have. So that's what we can do in the West, and we can be very effective at doing that. For the rest of the world who can't afford expensive phacoemulsification equipment, excellent and highly skilled surgeons have been able to develop a technique where they can still do relatively small incision surgery without the need for stitches, because stitches cause problems. They break, they cause infection, they cause irritation, and left in a stitch can eventually cause loss of vision from a secondary infection, which can track down a broken stitch. So colleagues across the world have been able to come up with this operation, which you see bottom left. The incision, this is the lens coming out, but the incision is made in the sclera. It's about the same width as the cornea itself. A tunnel is made into the sclera to enter the eye. And then top left in picture A, the capsule around the bag is opened and lots of hydrodissection is done. So lots of water is injected into the eye to loosen up the lens. And your natural lens or cataract basically consists of 3 parts. And it's the inner part, which is the oldest and that part free. So using lots and lots of fluid, you can get that free. And then an instrument is placed under the incision flap, under the lens, and at the same time it will irrigate. So you're constantly maintaining the eye and you're pushing the back of the bag backwards, and you gently ease the central part of the cataract out of the eye, leaving you with an empty bag with a few fibers, which you can very easily aspirate out. And then it is possible then to put in a lens, and your cataract surgery is done, and there's no stitches used, and the lens will, the incision will heal itself. So it's basically small incision surgery without the need for expensive equipment. And in eye camps in the Middle East, across the world, skilled surgeons can do this operation in 5 to 10 minutes. It can be extremely effective. The question has been asked is why aren't... Hello?
Yeah, if anyone could please keep their microphone off if they're not speaking. Thank you.
Thanks, Fahim. So the question has been asked is why aren't we doing that kind of surgery in the West? It's a great deal less expensive, but it is a slightly bigger incision, so there may be slightly increased risks. But as I say, the skilled surgeons who are doing this across the world are very good at the operation. In the West, we have lots of diopter lens implants, and here's lots of pictures. Some of these lenses towards the bottom have a multifocal part to it. And the idea being you're trying to put a lens in so a patient doesn't need glasses afterwards for distance, for intermediate, or for near vision. But you don't get something for nothing. So multifocal lenses can cause glare and halos and can have problems for people driving at nighttime. I personally don't use multifocals, but there are patients who've had them who think they're fantastic. Across the world, 5% or less of all cataract surgeries use a multifocal lens. And unsurprisingly, it does add a lot of expense. What is happening, because the drug companies haven't had a huge uptake with these multifocal lenses, is they're now making a monofocal lens with a slight adaptation to the center of that lens to try and give a dual focus, to give more near vision, but still in what's marketed as a monofocal lens. But we can actually give people spectacle independent vision using a standard monofocal lens by giving patients distance vision in one eye and a little bit of near vision in their second non-dominant eye. About a third of my patients have that, and that can be extremely effective. So we just talked about that there. And if you get spectacle-free vision, depending how much near vision you give in the second eye, you can tailor that to the patient's need as to whether they want simply to be able to see the intermediate level for computer or the dashboard, or if they're spending a lot of time reading, they may want to have a little bit more near vision, but you can tailor that to each individual patient. In the Western world, lens power determines what the focus is, but this requires another machine to measure it. And currently that's accurate in 80% of people to within a half diopter. But of course, that's another piece of equipment, so it takes more time and it has more cost. Elsewhere across the world, you can use a standard lens. A 21 diopter lens will give most people, most eyes, vision probably within 2 diopters of emmetropia. And for people who are clearly myopic or long-sighted, then you can probably make a best guess as to what lens power to use. If you don't replace the lens after taking out the cataract, then you have to put something like a +19 lens in front of the eye, which is obviously a very, very powerful lens in the glass, which distorts things. So aphakic glasses, which used to be commonplace in the 50s and 60s, are best avoided. For some reason my slide is just frozen. So whilst modern cataract surgery with both techniques described above is extremely effective, there are issues putting lenses in eyes. The bag or the lens itself can move. And in more elderly patients, the zonules, which are little ligaments which keep the capsular bag in place, which hold the lens in place, that can become weak, and it can be damaged by trauma. It can be damaged during the surgery. Modern monofocal lenses are designed so that even if there is some displacement, they still function, they still work. And it's only when the lens is moved out of the optical axis that the lens will no longer be effective. At the bottom and the middle, the lens is displaced fully, and clearly at that point, it isn't going to be functioning. The other main issue with cataract surgery is you can get swelling at the back of the eye in the retina, and this can happen between 1% to 2% of people. 50% of this swelling at the back of the eye will go away by itself. In the West, we treat this with some further drops, and you'd expect probably 98% of people to resolve after one course of drops. So the overall risks of cataract surgery, like any operation, include infection, but this is about 1 in 5,000 in the West. You can have a secondary pressure rise, particularly if there are complications. Bleeding in the eye is extremely rare, again, about less than 1 in 4,000. Myopes are more at risk of retinal detachment, but that's probably around 1 in 1,000. The younger the patient, the more risk for the detachment post-cataract surgery. Corneal clouding, if you have complicated cataract surgery, or when you're doing the surgery, you're not careful to protect the cornea, you can damage the endothelium, the inner lining of the cornea, and you end up then with a cornea which goes white and the patient's unable to see. And the only method then is to replace the cornea. In the West, we could replace a single layer. We talked about this, about the cystomacular edema, but normally that will go away. So in Western medicine, cataract complications overall are less than 2%, and the majority of them, be they inflammation or pressure or swelling, will actually get better. So even people with significant swelling, usually by 3 months it will fully resolve. Elsewhere, the risks are going to be a little bit higher, but generally with skilled surgeons, those risks have come down, and there is continuous improvement. The effect of COVID has been that all routine surgery was stopped in March, and it only just began at the end of July, and currently we're probably operating between 25% of what we were doing. So waiting lists were already reasonably long, and now they're becoming very long. The effect we've heard already on patients, I speak to lots of elderly patients, and most have already been isolating and are already anxious. There's a few people telling us, well, we lived through the war, so this is nothing, and they want to get on with their lives. But the majority are very concerned, and the effect basically has been that their cataracts have got worse, so they've become more isolated because they've become more visually impaired. People are losing loss of daily function, reading, seeing TV, being able to see their phones. So there's increased anxiety, increased depression, many things we've already talked about before, which are very important. And in the diabetic population for cataract surgery, the risk of swelling in the normal population was 1 to 2%. The diabetic population, it's more like 5%. So many of the things we've talked about are extremely relevant.
Ray, if we can come near the end now.
we're right near the end now, thank you. So for the future, and most patients, when you mention this, are terrified at the prospect, although we all get in planes and the computers fly the planes, and we're not too bothered about that. But in the future, this is getting close. This is going on all over the world in laboratories, universities. Fully automated cataract surgery is happening. And it could be in the future that the whole cataract assessment is done remotely. The measurements are done remotely. High volume, semi or fully automated surgery could be possible. And once this gets going, of course, the surgery may not be required, and cataract surgery can be carried out 24 hours a day if you can get to the facility, which will certainly increase the access. So cataract surgery is the gift of restoring sight, and is hugely appreciated by patients. And as we talked about before, those with dementia, I do many patients with dementia, and you can often see a quite marked effect on them afterwards. So there we go. Come to the end. Thank you for your patience. Any questions?
Thanks, Ray. We just got a couple of questions and then we'll move on. Is there a difference in the rates of after cataracts between the two techniques mentioned in your presentation, the phase and the non-phaco style?
In terms of the recovery?
It looks like after cataracts, so I'm assuming, yeah, recovery.
Recovery in the hands of a very good surgeon will be very similar. If you protect the endothelium and you get the lens in position properly, then the results will actually be quite similar. In terms of after cataract, posterior capsular opacification, which is where the back of the bag goes hazy, the main thing with that is to clear the soft lens fibers away and to put a lens in which sits comfortably within the bag. I suspect that the rate in the West will be lower.
Excellent. Thank you so much, Ray. And just the last one, it may not be your speciality, but there's a question on lens surgery for myopia. What are your thoughts on that?
Laser surgery or lens surgery?
It says lens surgery, but I think it's getting at laser surgery, isn't it?
Right. Well, if you're myopic, you can put a lens inside the eye. You can almost put a contact lens inside the front chamber of the eye, in front of your natural lens. So that's an option that can work. And you can take it out later when you do the cataract. That's an option. Or you can laser the cornea to change the shape of the eye. But myopes often have a thin cornea, which limits the number of myopes who can have it. I'm personally not a fan. But if you're young and you're struggling with everything else, then it is an option. But I'd go to a reputable refractive surgeon.
Excellent. Thanks, Ray. As we're just moving on to the final speaker, I just want to mention to people, in case they do need to rush off, that please can you fill out the feedback form? So that's at the top of the chat bar, right at the beginning. There's a feedback form on Jotform. It's really simple to fill out and gives us feedback on today's sessions. Please do just take 60 seconds of your day just to fill that out for us. There's also a good link that one of our speakers has put onto the actual chat box from BGS, the British Geriatric Society. So for further information, obviously, and that was from the presenter on COVID in older people. We now move on to Mehran to introduce our final speaker, and then please do stay for the Q&A straight afterwards. Thank you so much.
Thank you, Fahim, and thank you again, Ray. It was a really informative and educational talk that you just gave. So our next speaker is Dr. Fiza Salam. She's a general practitioner in the Brownlow Health Centre in Liverpool. She's also the Deputy Chair of the Tackling Racial Inequality Working Group for Central Liverpool Primary Area Network. So clearly the focus is around systemic racism and trying to address health inequalities, both from the side of patients as well as staff. So over to you, Dr. Salam.
Thank you and welcome, and thank you for inviting me this evening. Can everyone hear me okay?
Yes, we can, yeah.
Fabulous. Okay, so be kind to me. This is normally something I would spend a few hours to talk about rather than 10 minutes. So what I ideally want you guys to know, or at least be able to partially answer, is why have so many ethnic minorities been so badly affected by COVID, and why have there been more deaths among them? About understanding health inequalities. Excuse me, there you go, sorry. So I love NHS England's definition. It is unfair, unjust, but more importantly, preventable differences between different population groups that stops them from having a healthy life, accessing help when they become sick, or accessing treatment. And with most things, it is a complicated, multifactorial problems. You've got politics, you've got where you're living, the environment, funding, how much healthcare services are available in the area. Then you've got protected characteristics on top of that, crime, violence, and then you've also got structural racism and the history and impact of colonialism running in the background. Now, I am going to focus on just racism and ethnicity. I think it's important to understand what I mean by racism. It's amazing how many people don't fully understand this term. Racism is an umbrella term, and you can split it into structural racism. So this is where you have sort of changes in society that essentially set you up to fail. How the police are organised, how the geography is organised, transport links. And as you navigate through life, think about adding an extra shopping bag that someone has to carry until they just can't carry anymore, the bags drop. Then there's interpersonal racism. So this is what people tend to think what racism is. It's about the physical and verbal aggression, but it can be subtle. Things like policing tone, microaggressions. Common one I come across is the question, where are you from? And if I say the northeast of England, where are you really from? And then you've got institutional racism. So this is where you have policies in place that discriminate. So that could be policies around annual leave. And I've seen that in the NHS, where they assume if you have a certain type of surname, you're happy to work Christmas and put you on the rota. Without asking it, do you celebrate it? Disciplinary processes and hiring practices are also examples of institutional racism. So this is a good example of employment practice. So this trend is seen across the NHS. And you can just see here at the lower end of the banding where there's less pay, you have a disproportionate high number of ethnic minorities. As the pay goes up, the numbers just drop. I mean, it looks like a DNA helix. Whereas here, if you're white ethnic group, much lower, but as the pay goes up, the numbers shoot up. And again, this is really talking about more interpersonal racism. So if you're going to face a discrimination in the NHS, it is much more likely to be due to your ethnicity or race. And whilst many of them have remained stable over the years or even got better, unfortunately, discrimination based on your ethnic group has gone up. Now let's talk about poverty. Sorry, I am being quick. So if you're an ethnic minority in England, or the UK, you're simply less likely to have a job. You're much more likely to be employed, particularly if you're a woman who's Pakistani or Bangladeshi. Even if you have a job, you are likely to be in the lower end of the income at the bottom 40%. And there's very, very unlikely that your income will improve as you continue working. And this prevents people accumulating wealth, and wealth begets wealth. Wealth improves generations. It's your ability to put money in savings, your ability to invest towards a mortgage, your ability to help out your children, and your ability to weather storms like unemployment, which we know is on the rise and is only going to get worse. And if you're an ethnic minority, you're much more likely to, unfortunately, not weather the storm coming well. Then housing. Housing is important because if you can afford a house, when you sell that house, you get money back on that investment. And that's money that can help children. That's money that can help your family. That's money that you can help yourself. For example, if you get older, you need carers. And what's also important is what renting forces you to do. It forces you to live. So if you do rent, that renting quality is much more likely to be worse, much more likely to be overcrowded, which is important given the pandemic, but also creates natural segregation in the UK. At the end of the day, I do want you all to think about, growing up, was there certain areas where you lived where mostly ethnic minorities lived? And were those areas also linked with crime? Did those areas have access to good schools, good transport links? Because if most of your money is going on rent and you can't afford good housing, what options does that leave you? Also, homelessness is on the rise for ethnic minorities. So crime, unfortunately, you're much more likely to be accused of crime if you're an ethnic minority, particularly Black men. This is also seen in Black juveniles. Interestingly, whilst Black juveniles are much more likely to be arrested, they have the lowest conviction rate of any ethnic group. Says a lot, doesn't it? And if you are convicted, actually, based on the colour of your skin, you're going to get a longer sentence as well. And if you are not criminalised as a youth or for walking down the street, you're much more likely to be the victim of a crime. And unfortunately, hate crime has doubled since 2012, and the vast majority of that, 76%, is race hate crime. And actually that number's gone up since due to COVID and Black Lives Matter as well. Now, education, the thing that allows us to progress in life, the thing that gives us opportunities in employment. What's really good is all ethnic groups are actually much more likely to enter higher education than the white ethnic group. You're also much more likely to do better in school than the white ethnic group. But as you saw in my previous slide, that is not leading to job options for them. And if you're Black Caribbean pupil, unfortunately, you're also just much more likely to be expelled as well. And they made it harder to expel students in a case study in London. And interestingly, the Black Caribbean number of students plummeted. The number of white British students excluded didn't change. Health, we all know about postcode lottery. Unconscious bias from healthcare professionals leading to worse health outcomes. Not listening to ethnic minorities when they come in with complaints. BBitis is a term I've heard. And I want you to reflect if you've ever heard anything in the workplace that you thought, ooh, joke's a bit close to home, and you never said anything. Now, all of this adds together. Now, I'm not saying if you're white ethnic group, you haven't had hardship, or you've not dealt with homelessness or poverty, or not gone to a great school. But what you need to understand that purely because of the colour of your skin in the United Kingdom, you are more likely to deal with more barriers. And those barriers are more likely to be worse. Now, what I'm next going to go on is I'm going to talk about the physiological impact of experiencing racism. Now, this has been shown to be independent of health inequality, so this is something to add on top. That rhyme in school, sticks and stones will break your bones, but words will never hurt me. It's not true. So this is Harvard Uni's done some amazing work actually around adverse childhood experiences. And they recognize that racism and community violence is a major cause of this. Now, what is adverse childhood experiences? So when a child feels threatened, their fight and flight system kicks in, the limbic system gets going, and it starts firing constantly. They feel constantly stressed. And even when they're removed from that stressor, it still continues firing, and this leads to changes in their body. It increases their risk of heart disease, it increases diabetes, they're more likely to have obesity, as well as substance abuse, smoking, poor academic achievement, and everything else. And this is on top of the other barriers that they're having to deal with. And you got to bear in mind that even in adulthood, so may not have experienced as a child, but experienced as an adult. Imagine walking into work, having to put on a bulletproof vest because of how you're treated, whether that's conscious or unconscious. If you get a complaint thinking, is there a racial aspect to that? Coming to work as a doctor and knowing that you're twice as likely to be reported to the GMC than your white colleagues, which the GMC in their Fair to Fair report acknowledged that racism was a huge factor, and the fact that people felt uncomfortable speaking to someone of a different ethnic group. And that's also seen in the Nursing Council as well. And this has an accumulative effect. It literally knocks decades off your life. So a white English ethnic group at the age of 61 and 70 is equal to the Caribbean ethnic group in their 40s to 50s. If you're Indian ethnic group, that drops down to your 40s. Pakistani, your ethnicity, that drops to your 30s. If you're Bangladeshi, it drops to your 20s and 30s. This is sometimes referred to as biological weathering or accelerated aging. But what it basically means is whatever's on your birth certificate, physiologically speaking, you're older. And this fits in with a lot of the trends that we see. We see that a lot of ethnic minorities are coming into our clinics, are seeking help at much younger ages. So I want to end on really this note. When Public Health brought out their long anticipated report about the impact of COVID-19 on the ethnic minorities, it didn't mention genetics. It talked about the long-standing inequalities that were already there. It talked about the economic advantages that had caused health problems. But I would end on this note, that we have a legal duty and a moral responsibility to reduce these inequalities. They're not set in stone. There are things that we are able to change. Thank you.
Thank you so much, Dr. Salamfiza. We've got a question. How much data is there around healthcare processes and race? For example, response times to early warning scores, CPR outcomes. What do you think the priority areas should be around data collection for patients with regards to race?
So my answer to that is, why are you collecting data? We have enough. What is collecting more data going to tell us that we don't already know? This year alone, we've had some major projects come out. There's been the racial disparity audit by the government. RES has come out with data. There was a major report on learning disabilities where children who've died, who've learning disabilities, 49% were ethnic minorities. You're 5 times more likely to die if you're a Black woman in childbirth. Why do we need more data?
Thank you so much. We're now going to start the actual Q&A with everyone. Can I please ask the presenters who are still here if they could unmute themselves and actually put their actual videos on as well, so it's quite clear for everyone to see who's still here. And we'll actually run through some of the questions that are on the chat screen as well. And if you are wanting to ask a question, please can you actually write on the chat screen who the question is for now, as it will be confusing with all these speakers now available. So I want to actually just thank everyone as well who's been a speaker today, and also to all the attendees. It's really been very good to have you all here, and I'm really grateful for your time and attention. Okay, if I can actually go to Dr. Vardy up there, going from left to right, really. So we did have questions to do with actually this whole process that you mentioned in terms of delirium. In terms of the infection, can you just slightly expand upon that? What kind of infections do we need to rule out for delirium?
Infection is just one cause of delirium. So any infection, I guess some are more common than others. So respiratory infections, urinary tract infection, you just have to be really careful of that. I'll come back to that in a second. But also central nervous system infection and COVID, we're not really sure why it would precipitate delirium. It could be direct cause, so there's evidence that it crosses the blood-brain barrier. There's some evidence of white matter changes, looking at brain imaging data, but actually it may be indirect effects such as low oxygen levels, hypoxia, increased levels of inflammation. And what the caution I just meant in relation to urinary tract infection is because delirium can often, there's a bit of a myth that a lot of delirium is relating to urinary tract infections, and so it's helpful to look at what the definition of diagnosing urinary tract infection is and when to treat it. And it's just that it can be commonly presumed that delirium is related to a urinary tract infection, and if you don't do the other investigations, you can miss other causes, for example, hip fractures, myocardial infarction, and other causes. So it's just a bit of a word of warning around that.
Okay, excellent. Dr. Azmi, if I can come to you now. Thank you again for your presentation on diabesity. We talked about the sugar tax, but there are other factors as well in terms of this diabetic phenomenon. And one of them is also to do with BMI, is whether that's an accurate indicator of things. Obviously, we all know where that's not the only indicator. I mean, what do you say to people or questions where they ask about there are other factors to find out what your risk factor is in addition to BMI, and other tools in addition to BMI.
Yeah, so certainly BMI is an indicator, and it's kind of a crude indicator to suggest that once your BMI goes above 25, for example, you're overweight. However, in one of the slides I showed earlier, it's not just based on BMI and being overweight. There's a lot to do with the central obesity and simply your waist circumference. Waist circumference going up is a significant sort of indicator for cardiovascular disease and for development of diabetes as well. So there is several factors, and we need to sort of take these, put these together. And so if a patient was to ask me, I'd obviously, certain things I would say was obviously look at your waist circumference, especially in Asian people, because there is a central obesity where their BMI is fine. A lot of these people will come and their BMI will be 24, 25, and actually it's not good enough because it's central obesity. They've got quite thin legs and thin arms and the weight's just in the middle. So overall your weight hasn't gone up. So there are other factors, definitely sort of your waist circumference is quite important. In conjunction with the BMI. And I suppose the other thing to be wary of is the lower BMI and lower waist circumference cutoff for patients who are of Asian origin. They've got more, there's a genetic predisposition to having worse sort of risk for cardiovascular disease and risk for diabetes. So in these patients, we've got to make sure that they're actually, the waist circumference is lower and the BMI is lower than sort of the general population which the BMI cutoff was sort of aimed at.
Thank you for that, Dr. Azmi. If I come to yourself, Mr. Radford, we talked about cataracts, and it was a very informative update. I guess when it comes to COVID and what it means, is there any evidence to suggest that it's actually worth doing bilateral cataract procedures?
So that has been talked about in the European Journal. And if you want to do it on a purely economic basis, absolutely. You can do it more efficiently. The risk is there's like a 1 in a million chance, if you're unlucky, of having a bilateral infection, which would be a total disaster, and you would lose all vision. You'd lose the advantage of fine-tuning the biometry, fine-tuning the measurements. I do bilateral surgery, simultaneous bilateral surgery for some patients. For instance, if they do have dementia, coming into hospitals, it's an extremely stressful event. If they have other medical illnesses, we give them a general anaesthetic, and they've got cardiovascular risk factors, and we're only going to do it once. So we do it. We treat each eye as a completely separate operation. So we use different batches of equipment, gels, lenses, do everything we can to make sure it's 2 separate operations in time, even though that time was only 5 minutes apart. And touch wood, it's always been fine. So there is a push to do that on an economic basis. And there are times when it makes sense to do that. But would I personally want bilateral cataract surgery, given the advantages of separating it and all the fine-tuning bits about the lens and seeing how your cornea responds and seeing if you're at risk of cystoid macular edema? My preference would always still be to do them on a separate basis.
Excellent. If I can come to you, Dr. Raza, now. Any role of beta blockers in preventing complications from COVID-19 cardiomyopathy?
Okay, yes. Now, first of all, let me make it clear that the management with COVID-19 related heart disease will be no different from the usual care we provide to patients who have cardiomyopathy. Now, obviously, beta blockers, they are important treatment in cardiomyopathy, any cardiomyopathy, irrespective of the underlying cause. Now, beta blockers, as we know, has got effect on the catecholamines and suppresses the catecholamines that have got detrimental effect on the heart function. So beta blockers can not only regress the ventricular remodeling, but it can also reverse the cardiac remodeling, meaning thereby it can preserve and improve the left ventricular ejection fraction or its contractility. At the same time, beta blocker has the property to suppress any arrhythmia. So arrhythmia, as you know, ventricular fibrillation, ventricular tachycardia, they are the common arrhythmia, which can not only make the cardiac function worse, but it can also lead to mortality. So beta blockers, yes, will help in suppressing these arrhythmia as well. Now, just final point on this, you should choose the beta blocker well, I mean, all beta blockers are not same as So beta blockers that have been found to be effective through trials are metoprolol, bisoprolol, nebivolol to some extent. So these are the common beta blockers that you will be using in these patients.
That's great. Thank you, Dr. Raza. If I move to yourself, Fizar Salam, I know that, when we talk about health inequalities and disparities with reference to race specifically, Michael Marmot, obviously, during your presentation, he had produced that slide, but 10 years on, there's been very little difference. So there's two things. I guess the degree of spend, GDP spend, has declined over the past 10 years, and that's inadvertently affected. You could argue in terms of the more deprived areas. And I guess the second feeling is there evidence to suggest that these reviews should be done with someone who has actually experienced this degree of racial inequality and racial injustice?
Okay. So to answer the first part of that question, actually 10 years on, things have got worse. I was actually speaking to him the other week about it, and he was showing some of the data. So actually the difference in life expectancy, different ends of the country has worsened, particularly with women, and the north-south divide has actually worsened as well. So actually they haven't, well, essentially they've not listened to him. And there has been a link between how healthy the economy was pre-COVID to the response of the government and the number of deaths. And unfortunately, our economy was not good. The only other countries whose life expectancy fell was actually the USA and Iceland. I mean, I know the counter argument to that is always, hey, maybe we kind of got to our normal maximum, but everywhere else in the world, including Japan, which already had the highest life expectancy, has improved and gone up. So the second one to that is, actually, should ethnic minorities be the ones tackling these racial inequalities? No. Now, I'm well aware of the irony of me saying that as the deputy chair. Let me take women's rights as a good example. Women were not able to obtain the vote until men who were the dominant power gifted it and saw the value in it. Unfortunately, ethnic minorities have been trying to improve things, and they have not succeeded, and things have actually got worse because they're not the dominant power. They're not the ones in position of leadership. They're not the ones making decisions, whether that is in the workplace or society or regionally. And so unfortunately, they can't fix things without white allyship. The second thing as well to bring that onto it is cultural taxation. If you're already dealing with all these barriers, to then add on top of that the responsibility of fixing a problem that has existed for hundreds of years, it's a bit of a tall ask. And usually that works unrecognized and unpaid and adds to their burden. Fourth thing I would say to that as well is, it's not fair for our white colleagues to expect us to relive the difficulties we have in life for them to learn. There's loads of books, there's loads of research, there's loads of, you can go and figure these things out yourself. You do not require someone who's an ethnic minority, who's experienced bad things, to explain it to you.
Thank you, Dr. Salam. If I can move to Dr. Munavvar, President of British Thoracic Society, who's here and obviously has a key leadership position, as Dr. Salam mentioned, within the community. Can you tell us a little bit about the British Thoracic Society and how that relates to the public and healthcare professionals? And also, added on to that, how will this year's flu impact on the health service, in particular respiratory services? Thank you.
Thank you very much, Fahim and Mehran. Beautifully organized symposia, webinar, and amazing speakers. Thoroughly enjoyed it. First of all, congratulations. The British Thoracic Society, for those who may not know, is the only thoracic or respiratory or chest society in the UK. Having said that, it has 3,700 members, and a majority are in the UK, but it's a global organization. Global mainly because it is the leader in the production of guidelines for absolutely everything that one has to know about management of any respiratory condition. There are more guidelines and quality statements produced by BTS, British Thoracic Society, than any other organization. It's a well-oiled machine. which has been dishing out guidelines with a very clear methodology, a whole team behind it, reviewing data, studies, and producing the best possible guideline. The idea is to ensure high quality education, training for respiratory physicians, but also all allied health professionals who work in the field of respiratory medicine, so across the board, and to disseminate that information around the world. I mean, the British Society's the main journal is Thoracic, which has one of the highest impact factors amongst respiratory journals in the world. And when it came to, for instance, any crisis, such as, say, for instance, COVID, we have a whole team, and right from March till now, initially in the matter of about 6 to 8 weeks, we produced about 20 to 25 guidelines, which was provided free of cost through our website for every aspect of management of COVID in asthma, COVID in COPD, COVID in interstitial lung disease, and so on and so forth, even COVID in renal failure and anticoagulation, etc. The other thing is the British Thoracic Society works with Royal Colleges, with the NHSE, and to ensure that we collaborate and provide the best possible care to our patients for COVID-related respiratory failure and a variety of other conditions. Now, coming to flu, British Thoracic Society are heavily involved in encouraging the flu vaccination because, to be perfectly honest with you, we don't know what impact it will have on the health service. We are worried that it will have a very serious impact. How we're going to manage COVID and flu-related admissions to hospital. The best thing that we can do for now is ensure that all vulnerable people and all healthcare staff and everybody gets the flu jab for now to reduce the incidence of flu and try to manage COVID when they come in. But if they come in with both and the winter around the corner, we are seriously worried. Lots of discussions that take place between us and the Department of Health. Only a couple of hours ago, I was writing a letter to Sir Simon Stevens, coordinated through the British Thoracic Society, about various issues and things that we can do to help with the management of long COVID, which you alluded to earlier in the program. That's the kind of activity that we have day to day. We've had every Friday afternoon blocked off for the last 8 months for this particular work from the hospital. I hope that gives you an idea.
Yeah, we just had a couple more, Dr. Munavvar, for you as well. With so much advancement with focus on early diagnosis, is chest X-ray the first line of investigation for hemoptysis or coughing up blood? Or I guess the question should be, should it be?
It's a very good question because I think the question is in relation to the fact that even in hemoptysis, chest X-ray gives minimal information very often, and CT scan is a lot better. However, and for that reason, for good reason, some centers around the country allow direct access CT scans for GPs. However, the important point to remember is not everybody who coughs up blood has a serious condition, and there may be, we may end up doing too many CT scans with a consequent radiation exposure. But if we have certain guidelines as to how to risk stratify those patients, and then choose the right patients to go ahead and have a CT scan that is likely to be more productive. As it stands though, chest X-ray remains a useful investigation and probably reasonable to do as the first stop investigation. Besides that, the moment we see the chest X-ray, unlike in the past where we would send the chest X-ray report back to the GP, the radiologist or the department organizes a direct CT scan. So it saves a lot of time. And then that CT scan comes to us in the chest department and we straight away act and bring the patient in for whatever next investigation that is necessary in order to complete everything within the week, if wherever possible. Obviously, that's been delayed by COVID, but that's our target.
Excellent. And the last one was, is there a putative effect of COVID-19 infection with lung cancer occurrence? i.e., does COVID-19 infection in itself lead to mutational changes that lead to cancer?
We don't know. The answer, correct answer would be, because it's on that front, it's early days. Theoretically, COVID-19 could cause a lot of problems because it's we've seen a small but significant incidence of pulmonary fibrosis coming through past COVID-19. Of course, thromboembolism, which we have seen quite a lot of. So whether on the back of that longer term, I mean, we'll have to wait and watch. It's too early to say one way or another. But COVID-19 has caused some serious effects, and we are monitoring, and we have a COVID follow-up clinic for this purpose. We have long COVID service for this purpose to try and study and learn more about the impact of COVID.
Thank you so much.
Thank you, Dr. Munavvar. Dr. Akpan, I wanted to ask you about your kind of personal experience about virtual wards. How have you found it? And do you think this is an opportunity for them to stay in the current COVID situation?
Sorry, could you repeat that question?
About the presence of virtual wards where we're having to review from a distance, especially when we think about care home residents and the current situation.
Okay. So there are different things depending on which part of the country you practice in, but I'll describe what I do now. Most of my work now is remote. And to be honest, it's no different from when I would be discussing a case over the telephone with an advanced nurse practitioner or a GP. So we would discuss a case and I'll be able to give some clinical advice or support to them. If I'm directly involved in the case where I am speaking to the patient or their carer, then that's even easier because usually there's a lot of information already available. So these patients have already had lots of investigations and there's lots of information available on the GP records, which I have access to. So it's not too difficult to make a decision about what to do with the person. The virtual wards I was referring to is something that has been set up mainly in the South, but I know it's coming up in Manchester and is specific for COVID, and is to try and manage patients with milder degrees of illness outside of the hospital. Now, I have not been involved in that, but I think it's coming to Liverpool, and it's very likely to be led by the respiratory physicians who already have a lot of experience managing patients with long-term lung conditions outside of hospital. And also, I think acute physicians, and so that's about virtual wards. The other virtual wards that some other people have set up is in relation to the frailty assessment unit. So some people have doubled or tripled their capacity by having a hospital at home service where they can look after people in their place of residence.
Thanks, Dr. Akpan. We've got a question for Dr. Azmi while you're still there, and it's to do with intermittent fasting and the 800-calorie diet that's been out and come into the news in particular. Obviously, weight loss is a big thing. COVID-19 has brought that into focus quite a lot. And obviously, Public Health England has its own take in how to lose weight. What are your thoughts on what's the best way for members of the public, healthcare professionals, etc., to lose weight?
So yeah, at the moment with COVID-19, everything is quite topical. Everybody's trying to get in the best health possible. And I suppose it's something we need to be doing generally anyway. So we talked about I showed you data on the low calorie diet and how it's the evidence for how it can lead to remission in diabetes. The difficulty with a lot of these things is if you're out there doing it by yourself, it may not be the healthiest way to go about doing it. So if we can't, it's very difficult to simply say to patients, yes, go away and do an 800-calorie diet, because they may not get the adequate nutrition and they may not be able, they may not have the knowledge required to sustain that. Obviously, these studies, they're done in a controlled environment where they've got dietitians and you've got, the patients are selected, you've got sort of a carefully controlled environment where the patients are actually having 800 calories, because obviously it potentially may not be, obviously it's not as healthy if you're not doing, if you're doing it by yourself sometimes. So that's the difficulty when we give this information out to people, to the public. Obviously a little bit of knowledge is good, but too much knowledge sometimes is not in the right hands, may not be beneficial. So certainly intermittent fasting and the sort of low calorie diets have shown really good benefits. And they're gonna be, I suppose the future now is trying to integrate this into our healthcare. So certainly there's pilot studies going on trying to, in general practice at the moment, and in Manchester, there is a pilot looking at low calorie diet for obviously to improve for a remission of diabetes and to improve obviously obesity. And I think these are needed now to see how it will go, how the general population will respond. So there is promise. However, I wouldn't advocate somebody going out and cutting down to 800 calories. Saying that, obviously 800 calories is an extreme is a massive reduction. You normally aim for about 2,000 calories. That's sort of what we aim for. Majority of people have a lot more than that. So any reduction in your daily calories is an improvement. So as a general population, if you're not doing it as part of a weight management program, if you just want to generally get healthier, I would advise to just try cutting down your calories in the first place. So you don't need to go to 800, go to 1500, go to 1700, look at what you're having and cut it down by 10%, cut it down by 15% in the first place, so that you're not going into a starvation mode by yourself at home with no sort of access to see, you know, whether your things are going in a healthy manner. But certainly I think it's really promising data, and it just shows that there is opportunity for remission in diabetes and improving, and even sort of obesity without diabetes, to improve health outcomes. So I would say at the moment, just if you're doing it by yourself, you need to sort of cut down the calories until we have sort of more wider data as to how patients can do this by themselves.
Thank you, Dr. Azmi. And we've just got a final question. My apologies to all of you who've sent me messages for questions. We've obviously run out of time 45 minutes ago. And that's for Dr. Fiza Salam. We know the impact of the various forms of racism, particularly structural and institutional racism. It seems like an uphill battle. How can we as healthcare professionals respond? Are there simple measures we can implement to improve things, I guess, from tomorrow?
Okay. So I think if you did something that you changed today, right now, and to improve things, then actually my advice would be about looking into and reading about bystander training. So that's, what do you do when you witness someone experiencing racism? And I actually would say, think about how you'd respond. So a common example in the NHS is patient turns up and says they don't want to see anyone who an ethnic minority doctor. They only want to see a white doctor. Well, actually, how do you respond to that? Now, it does put you in a difficult position as a clinician, because actually in that moment, especially if they need urgent help or it's an A&E department or a ward, you can't deny someone care. But what you can do is show compassion to your colleague. And I think what often happens in that moment is we are really good in that moment to say, are you okay? But in that moment, when you've got a list of jobs, the ward's busy, your bleep's going off, you actually haven't had the headspace to process that information. So actually ask them if they're okay, but also ask them if they're okay a week later. Ask them if they need to have a chat, but also report it. And there was an amazing one about recently, I apologize, I want to say it was Blackburn Hospital, but I would have to double check that, where a patient put a complaint in about how the fact that they were told that it wasn't appropriate for them to say that. And actually, the director of the hospital reported them to the police. It is a criminal offence. The second thing is, and what is much harder, is what happens if you witness a colleague saying it to a colleague or someone who's a senior position. And it can be subtle. It can be very, very subtle. It's always picking someone else for an opportunity. That individual was being sent for coffee, not being given the same opportunities. And so for that, I would say is have a conversation privately about how they're doing and how they can be supported to do that. In secondary care, I would say if you're the head of a department or a trainer, find out about who your freedom to speak up guardian is. Now, that's a little bit different advice if you're primary care, but if you're secondary care, trust CCGs, find out who your freedom to speak up guardian is. So even if your colleague doesn't feel comfortable going through formal processes, bearing in mind historically they don't go well if you're an ethnic minority, they can still report it to the freedom to speak up guardian. And if same individual is getting reports from a lot of reports, they can actually bypass the disciplinary process and go straight basically to the bosses to say there's a problem. They can also support anyone in work. So that doesn't have to be doctor, nurse, ward clerk, So yeah, they can absolutely do that for you. Primary care, we're working on it, and I'm sorry, I have not got a better response from that. Unfortunately, you don't have access to freedom to speak up, but we are in discussions about starting some trials to allow primary care workers that access to it. My next bit of advice is find out if you've got a BAME network. If you don't at the moment, it's a key priority of NHS England to bring one in and to contact them for support as well. Does that help?
That's great. Yes, thank you. Thank you, Dr. Salam. I just want to, I guess, wrap up. We're way overdue on our allotted time, but I do sincerely appreciate all the time and energy you've spent answering the questions as well as sharing your expertise. Special mention to obviously Dr. Leroy and Dr. Vardy, Mr. Radford, who has now left, but also in our thoughts is Dr. Sadiq and Dr. Jia, who couldn't contribute to this meeting. But thank you again for the audience, both within this meeting as well as on our YouTube channel. I know you've been very attentive and have been sending questions through. Please do like, please do subscribe to our channel. This is one of many in the future, hopefully. But again, I just want to thank you again, as well as Fahim, our co-host, for getting all this together. And, you know, please do keep us in your thoughts and prayers as well, and you guys are all in ours as well. So thank you again.
Thank you, everyone, and stay safe and stay well. And thank you again to all our presenters and attendees. And you can obviously catch up on the whole show on YouTube right now. Thank you so much.
Thank you for inviting me.
Thanks, everybody. Bye-bye.
Thank you.
Thank you. Bye-bye.
Bye.